All right. Well, good day, and thank you so much for joining us. We'll start right at the top of the hour. This is indeed our DOPPS Autumn Update meeting, and we have just so much to present today over the next 3 hours. We're so appreciative of your joining us. Yeah, in years gone by, now we had this event specifically at the ASN. We chose to have it a couple weeks in advance for a few reasons. One is that, first of all, the ASN was a little more challenging with respect to access to meetings of this sort. But most importantly, we're still recognizing that many of our colleagues have difficulties with travel internationally, and we're really keen to assure that we open this up to all of our DOPPS family members worldwide. Okay, good. I'd like to start first of all by thanking our corporate sponsors and really considering these as colleagues and partners with us in support of the DOPPS program and all that we do. So many thanks to you. Next slide. And as well, warmest of thanks to all of those who made the DOPPS program possible. We have now, this is now our 26th year since 1996. So our country investigators, consortium sponsors, especially our CRAs. The CRAs worldwide just do so much to help keep the study functional and moving forward. Our site investigators, study coordinators, and especially our patients. I did want to note a word in memoriam for, thanks for with respect to Dr. Takashi Akiba, whom we heard just passed away within the last several weeks. Dr. Akiba was, many of you I think on the phone will know Dr. Akiba, those who've been with the DOPPS for a while. He indeed was one of the founding Japan Steering Committee members, and with us on the steering committee through the end of DOPPS 6, that is about 20 years. Dr. Akiba was always generally soft-spoken, but everything he said was just so important and insightful and passionate. And in addition, Dr. Akiba had a good number of fellows and trainees that we worked with, supported many younger investigators as they launched their careers, and worked along with us and Dr. Akiba. He himself was very involved with much of our research as well. So indeed, Dr. Akiba will be missed, and from the DOPPS family, we send our condolences. Right, we have been, DOPPS remains very active, currently in 19 countries, nearly 800 sites across our 3 studies. Really just a ton going on, and I won't spend more detail on this slide as we'll get to these with each of the separate studies a bit later in the session. We have remained very active with our research, and those of you who've attended our meetings have seen a slide like this before, but now with 2022 column, and we're still on par to have roughly the same number of publications. We publish roughly 18 to 20 publications a year. That is 1 to 2 every month or so, and remaining exceptionally active in that regard. And again, once again, a real team effort from amongst our colleagues internationally. Next slide. All right, well then, as we think about our 3-year study phases, as DOPPS 7 comes to an end early next year, we're really very much in the midst of planning for DOPPS 8 to launch later in 2023, with study goals that the top 3 are those that we've had for actually since our start, that is to describe real-world practice variation, to identify optimal practices, to serve as a resource for the community. On top of that, with DOPPS 8, we are so as I mentioned in the text book, our guiding principles are, number 1, to continue to innovate scientifically and continue to make a difference while at the same time doing everything possible to limit study burden. Goals include for DOPPS 8 understanding of longer term outcomes on dialysis. For those of you who look at the numbers, you'll see, for example, with the USRDS, that mortality beyond years 3 to 5 on dialysis, particularly hemodialysis, starts to rise quite rapidly. I do think there's much for us to do still with respect to understanding longer term outcomes. A real opportunity there with our study program. We're going to focus on new medications, new technologies as they're introduced to the market, We're focused, as always, on the patient experience, and now via what we call an EPQ, which is our electronic patient questionnaire. That will be issued in most regions, electronic patient questionnaire 4 times a year. So really, really exciting, really interesting. We have piloted that so far already in both China and in our DOPPS Europe countries. And then lastly, we're going to focus on the dialysis transition period. And with that, next slide, please. Right, so just to spend a couple minutes thinking about our focus on the transition to kidney failure. Some of our regions are going to implement DOPPS 8 as a hemodialysis study only, and in this case, oversample incident dialysis patients. In other regions, we're going to implement something new, which we're calling here informally a hybrid protocol, CKDopps and DOPPS, whereby we enroll patients with non-dialysis CKD and follow them as they start dialysis. In addition to enrolling prevalent samples of dialysis patients. And indeed, our third bullet, I note a triple protocol that would be CKDopps, DOPPS, and PDOPPS. So even under consideration following folks, whether they move on to HT or on to PD as well. Now, this approach, we think, meets a major unmet need in the community and really will be a great resource for studies. So this has been, to some extent, the holy grail in terms of studies of this sort, and it's very, very difficult to capture that transition period well, but we do think we're really set up to do so and able to start acting on that. I will note that feasibility remains a key focus. So we would plan in areas that we do implement this to implement in a pilot fashion, that is only at some sites. Sites are going to be selected not only on the basis of having patients who do transition from CKD onto dialysis at the same center, but also, really importantly, in the context of staff availability. We hear a lot, particularly post-COVID, all clinical research is really getting stretched. Resources are very thin. We must focus first and foremost on assuring we have staff who are able to and supported as they do the work necessary. And then lastly, of course, this always depends on funding. So regional models and regional study variations will depend on specific regional funding. We've had great movement in all regions of the DOPPS program worldwide, thinking about next steps for next year. Okay, and then next slide. Wanted to highlight again our collaborations with the International Society of Nephrology, which we're really very proud of and think is very important. I'll note Roberto Pacuafijo has been leading this interface. Roberto also leads or has recently led the educational programs for ISN. And in this vein, we put on several joint webinars. There's actually a screenshot on the top left related to PDOPPS. PDOPPS, please help. In other words, PDOPPS, you actually have data for us to base our clinical decisions on. And then next to that, a webinar on venereal bone disorder as well, and various other work that we've done together. With the ISN, we also just recently had 3 papers published together in Kidney International Reports describing results of a survey that we sent worldwide focused on COVID. Particularly pleased and proud of our work with lower middle income countries in this regard. And actually the success of this collaboration with ISN has led to the talk of some additional work together. And we are very much looking forward to opportunities to collaborate along with ISN, particularly in outreach to lower and middle income countries. Next slide. Okay, it was ASN, which is 2 weeks from now, and back in person, which is wonderful. We have a very busy session of ASN. On the left-hand side, you'll see we have a joint session with USRDS. This is the 2nd year in a row that we've had this. Both Dr. Pacuafijo and Christian Combe from Bordeaux will be speaking on behalf of the DOPPS program. I am giving a talk separately related to anemia management on Thursday. And of course, we have a host of posters as well. Next slide. And very importantly, we have a social mixer on the Wednesday evening just before ASN launches. So for those who are there in person, we really do look forward to seeing you there and catching up. It'd be so nice to see everyone after a number of years. Next slide. Okay, well, with that in mind, then moving on to our autumn update meeting here today. This is a 3-hour session. Those 3 hours will go by, I'm sure, quite quickly. We're going to split this up as we have in over the last several years into DOPPS and PDOPPS. And CKDopps, PDOPPS will be led by Jeff Pearl, who leads principal investigator for the PDOPPS study. CKDopps led by Roberto Fijo, who leads CKDopps. And Ron Bozzoni will moderate our DOPPS session as well. We are really interested in engaging with the audience, so please let us know when you have questions. Actually, next slide. Right, please use the Q&A feature. Actually, may look to you as questions feature. So submit us questions through the questions feature. We'll respond either in real time or collate many of the questions for a question and answer session. We have about 20 minutes of question and answer at the end of each breakout. So about 40 minutes of talk followed by 20 minutes of Q&A with a panel of speakers, and I'm really interested in hearing from you all. So thanks very much. Next slide. And with that, I'll pass this on to Ron Bozzoni, a wonderful colleague of ours, distinguished research scientist at Arbor Research, who will moderate the DOPPS session today. Okay, good. Oh, there we go, Ron. Can't hear you. I'm happy to get this rolling as Ron works on audio. We can see your face, but we can't quite hear you. Well, I'm happy to push ahead, and as actually Ron and I were just conversing through this just before the start, so something came up briefly, and we'll get through it. All right, yeah, next slide, please. Right, all right, DOPPS itself, this is our flagship hemodialysis study. You'll see here we have 14 countries participating. That does include the US, 7 European countries, China in 3 metropolitan areas, as well as Japan, and then the GCC in 4 countries. All of these are going very, very well. We've had tremendous success with data collection, tremendous input from the coordinators and CRAs as well. Next slide. And our long list of country collaborators, so many thanks to country investigators, so many thanks to all of you for your support for the DOPPS over the years, and for your innovations in creative thinking as we move things forward. Next slide. Right, I will note, over the years, and in particular with the focus of ours in stimulating collaborative research, we have made a point of assuring that we're sharing data as widely as possible with other academic institutions. And here I've listed our data hubs for the DOPPS program itself, that is in Ottawa, Manish Sood, a country investigator, in Beijing, Professor Li Zhuo with Peking University, and with the Japan DOPPS Steering Committee through IHOPE based in Kyoto. All of these have quite robust research outfits, and actually for CKDopps and PDOPPS, we'll show similar slides a bit later. Next slide. All right, so we have 3 talks followed by a Q&A session. And actually what's going to happen with these talks is the talks have been recorded, roughly 8, at the most 10 minutes each. Our speakers are on board with us live and will be part of the Q&A session as well, and be able to respond by chat during their talks also. With this in mind, I'd like to introduce Xinzhou Zhao from Beijing, China. Xinzhou is a great colleague of ours, working very closely with Professor Zhuo Li in Beijing. Xinzhou does much of the work to lead our China-specific research projects, and she'll present on those right now, including latest on HIF-PH inhibitor use. And actually, just before we get there, next slide, or can we move to the poll question? Very good. I was going to note, actually, for many of our talks today, we have poll questions right at the start. And here's the first one of these. Then please actually go ahead and vote for audience members. And we'll give you up to 30 seconds to do so. The question here is, do you use or expect to use HIF-PH inhibitors commonly for anemia management in your dialysis patients? Not per se non-dialysis CKD here, but actually dialysis. And indeed, the answers we've given are principally for incident patients, for ESA hyperresponsive folks, quite broadly, or you don't anticipate much of a role. And we differentiated here, but from the US versus non-US, as many of you know, we're in a different regulatory situation at the moment in the US, where HIF-PH inhibitors are not yet available, in contrast to a number of our other countries. Now, here we go. Wonderful. So our first poll results, I think you can see this. So we have 38% anticipate wide use for many types of dialysis patients. Among our non-US respondents, had a fair number, 38%, who said that they don't anticipate large role in the dialysis setting. Okay, and I don't see anybody who chose incident dialysis patients specifically. All right, very, very good. So with that in mind, let's move to Shinjo's talk.
Hello everyone, thanks very much for inviting me. I'm delighted to share DOPPS China local research updates. My name is Xinju Zhao from Peking University People's Hospital. Here is a managing structure and the 6 KOLs. This project is led by Professor Zuo. First, I'd love to introduce the study scope of DOPPS 8. We will continue and enhance DOPPS in-center HD study, and we will launch CKDopps for advanced NDD CKD patients, which is known as CKD pilot study. We will continue electronic patient-reported outcome project to expand our focus on patient-centered research. And then I will introduce the publications. Altogether, there are 7 publications, and the last 2 was published in our local journals. Now I will go into detail of some publications. First is thrombocytopenia predicts mortality in Chinese HD patients. This work was inspired by our unpublished work, Mortality Risk Factor in China DOPPS. The results suggested that platelet count might be a potential risk factor, and through reading references, we found a U-shaped association between platelet count and increased mortality in the general population and several diseased populations. However, few studies have examined the association of platelet count with all-cause and cause-specific mortality in HD patients. Through analysis, we found in Chinese HD patients, TP is associated with higher mortality risk of all-cause mortality, and CV death had a trend. So maybe platelet count can be a prognostic marker for clinical outcomes. However, we have several limitations. First is the patient group. We divided into 2 groups, but we could not further divide it into normal or above normal, limited by the sample size. Secondly, it's Chinese only. Thirdly, we are lacking of platelet function information, and we have no related drug information. So worldwide data will be used to do further analysis, which will address the first 2 limitations, but not the last 2 limitations. The second publication is about HCV prevalence and incidence. In China, we have a higher hepatitis C prevalence. However, it decreased. Let's see, here is the DOPPS study phase 4, 5, 7, and the prevalence decreased by half, and also the incidence. We also explore the cause of death and death patterns in HD patients. During the follow-up period, more than 200 patients died. The overall mortality is 14%, and the annual average mortality is 8.8%. The top three causes of death were cerebral vascular events, congestive heart failure, and pulmonary infection. 70% of HD patients died in hospital and others died at home. 80% of patients did not stop HD treatment, but 1 in 5 of patients stopped HD treatment before death. 43% of died patients received hospice care before death, which means we can tell the patient is dying. And the risk of death was highest in midnight to early morning in a day. These results are very interesting. And I'd love to introduce our draft manuscript about facility level serum potassium variability and mortality. We all know patient level potassium variability associated with adverse clinical outcomes. However, facility level potassium variability and outcomes have not been reported. So facility level potassium variability was defined as standard deviation in baseline values of all patients in each center. The mean SD value were calculated, and the center were divided into high facility level variability group and low variability group. We can see facility level serum potassium variability is associated with all-cause mortality and CV mortality across these 6 models. Notably, we added model 6, which reflecting some practice pattern, like mean facility level potassium concentration. The percentage of patients' treatment time less than 240 minutes, the percentage of patients using high-flux dialyzer, the percentage of patients using prescribed dialysate potassium less than 2.5, and the facility patient number, and so on. And we found some patient characteristics were served as influencing factors, like dialysis vintage, BMI, comorbidities, and primary kidney disease, and also some practice pattern factors like dialysis frequency and facility patient number, hemoglobin levels. And here, I also love to share a very preliminary results on real-world use of Roxa, a HIF pH inhibitor in CKDopps China, and which was accepted as ASN Kidney Week abstract. ESA has been the mainstay to treat anemia for decades, but have been associated with adverse outcomes. And Roxa was commercially available in China since 2018. However, little is known about its use in real-world settings. The aim of this study was to explore Roxa update in Chinese in-center HD patients. Here we can see the percent of patients prescribed with HIF pH inhibitor from 0 to almost 10%. Compared with overall patients, this 10% of patients are older, more female, on dialysis longer, and more likely to be diabetic. And they have lower hemoglobin levels compared to overall, but increased 2 months later. TSAT almost the same, and the ferritin was higher than the overall, and also decreased 2 months later. CRP higher than the overall. We can see most of the patients were prescribed with ESA before Roxa prescribed. And 2 months later, there are still 70% of them use ether, but with decreased dose. We have 3 ongoing analyses: machine learning to predict patient outcome, thrombocytopenia analysis with worldwide data, and erythropoietin resistance index, ether origins like original or domestic made, and mortality. Lastly, I'd love to thank our analytic team members. That's all. Thank you.
Okay, Ron, I'm not hearing you still. Either way, you can stay on, and we can keep looking at you and knowing you're with us. Anyway, Shinjo had a wonderful summary of all the work going on that's being led at the Beijing group. And I will note as well, over the years and moving forward, we're so interested in supporting and promoting junior and junior to mid-level investigators. And I think we'll see an example of this today, where many of our talkers, many of our speakers are in that career stage. So, all right, with that said, let's move on to the next talk. That is Angelo Caraboyas. Angelo's a wonderful colleague of ours, a biostatistician, epidemiologist here at Arbor Research, and many of you on the phone will know him and have worked with him and be so aware of his many talents. Do we have a poll question for Angelo? Right. All right, this talk relates to pruritus. Question for the audience: how often do you or your team ask your dialysis patients if they itch? And we give 4 answers here. And we'll give perhaps just a couple, 10 more seconds or so, and then we'll put the results up. I don't want to bias responses by my my thoughts here. Okay, so monthly, I was going to note that this has become more and more important as we recognize the importance of this to patients. That said, from the audience, we're hearing 40% say monthly or more, 30% every 3 months, 30% rarely or never, which is so interesting. All right, good. With this in mind, let's move on to Angelo's presentation. Thank you.
Hey, I'm Angelo Caraboyas, and I'll be talking about pruritus in hemodialysis, specifically the utility of frequently monitoring symptoms. So for some background, chronic kidney disease-associated pruritus, CKDOPPS, has a high burden in hemodialysis, typically shown in the DOPPS. About 35 to 40% of patients are at least moderately bothered by itchy skin. Itch has been associated with adverse clinical events, mortality, hospitalization, as well as patient-reported outcomes, or PROs. Most of our prior work has focused on a single baseline assessment of itch using one question from the KDQOL 36. There's a question of what about the utility of frequently monitoring itch symptoms? We have annually assessed itch symptoms in the DOPPS, but then we also have an ongoing electronic PRO or EPRO study in Europe, where we have been assessing pruritus symptoms every 3 months. And then also in the context of this EPRO, given the capabilities and flexibilities that it has, how can DOPPS help understand uptake and real-world effectiveness of treatment options for pruritus? So first, I wanted to show some of our data from our traditional DOPPS study, where itch was assessed annually. So here you see the proportion of patients whose itch symptoms either worsened got better or were the same at their year 2 assessment versus year 1, stratified by their assessment at year 1. So you can see that among those at least moderately bothered at baseline, about half or perhaps slightly more than half of those patients saw their itch symptoms improve in year 2. Conversely, among those not at all bothered by itch at baseline, 42% of those patients developed some itch symptoms by year 2. In terms of association between this longitudinal itch assessment and other patient-reported outcomes, we divided patients into 4 groups. You can see here, no, yes, no, yes, yes, yes. This represents whether patients were at least moderately bothered by itch in year 1 and in year 2. And on the y-axis, you see here the proportion of patients affected by other PROs, shown here as depression and also restless sleep. And so that illustrates the proportion of patients that either had depressive symptoms or were bothered by restless sleep. And the shapes here represent the proportion bothered in year 1, and then the arrow points towards what happened in year 2. So if we first look at the yes, yes, and no groups, you can see that the proportion, for instance, for sleep quality, the proportion who had poor sleep quality was 50 to 60% among those bothered by itch at both time points, and only 25% in patients who were not bothered at either assessment. One thing to note is that the sleep quality was better for the no group, as would be expected, but it was unchanged in both of those groups. In contrast, if we look at the changes in sleep quality in those subgroups of patients whose itch symptoms changed, here you see the difference where patients whose sleep quality, patients whose itch symptoms improved also saw sleep quality improve. Patients whose itch symptoms worsened saw their sleep quality worsen. And we're not claiming causality, but we do note that those within patient changes in sleep quality did track closely with changes in itch symptoms. We saw similar results for other PROs that we tested, including feeling faint and feeling drained. Next, I'll talk a little about our ePro study with more frequent CKDAP assessment than annual. By assessing every 3 months, I think we'll be able to better evaluate the extent to which itch is episodic versus chronic, and then also investigate whether patients more consistently bothered by severe itch had worse PROs than patients who maybe only recently developed severe itch. In our study, we plan to be in over 100 hemodialysis units across 7 European countries. The ePro will be distributed every 3 months on patients and accessed on patients' personal mobile devices. We'll capture multiple itch instruments, and not just the KDQOL question, but also 5D itch and the AI and WI NRS, in addition to other PROs and questions relating to healthcare resource utilization. We've enrolled already over 600 patients across over 60 dialysis facilities in Europe. And I'll show some preliminary data, but I'll also note that we do have a poster for ASN if you're further interested in some of these data. So this shows the WI NRS and the AI NRS, the worst itch imaginable, and also the average itch, stratified by the KDQOL question. And you can see the KDQOL was correlated with both of these measures. About 0.5 was the correlation factor. And so that was encouraging to see the the strong relation between the NRS scale and the KDQOL scale that we've traditionally used in DOPPS. As far as treatment options, gabapentin, pregabalin, and nalfurafine have been shown to reduce image symptoms. These are used infrequently, gabapentin and pregabalin, prescribed off-label to 5 to 10% of HD patients that are bothered by itch. Nalfurafine to about 15% of patients in Japan bothered by itch, but each of those have shown to have some adverse safety and tolerability profiles. More recently, DFK was approved for treatment of dialysis patients in the US, Europe, and elsewhere. And the DOPPS data, I think, could be very useful in helping understand DFK utilization, real-world effectiveness, tolerability, safety, and such, particularly via this prospective EPRO mechanism that we have. And lastly, I wanted to highlight a book and a course by our investigators that we've worked closely with on these itch projects over the years, Dr. Hugh Rayner, Dr. Nidhi Sukul. And this really helps describe the problem in detail, the impact it has on patients' lives. And there's also a podcast available here with a link and available wherever you can get your podcasts, the Fast Facts Nephrology podcast that I wanted to highlight here. So thank you for your time.
Yeah, no, Ron, yeah, I'll cover for you again. Our last speaker is Murilo Guedes. Murilo is a physician and a research scientist from Curitiba in Brazil. And Murilo's worked with us for the last 2 to 3 years. Just a great talent and a real pleasure to have on our team as well. Murilo has led a number of important projects over these past several years. So he will speak today on rise in serum phosphate levels. Actually, with that in mind, let's move to the poll question. All right, our poll question for the audience. What do you consider the optimal upper limit serum phosphate level for most hemodialysis patients? And we give you a range down from the upper limit of normal, laboratory normal, which is 4.5, up to less than 6.5. And indeed, if the audience can vote on this, we'll give you a few seconds. And as you all are putting in your responses, I'll note that we have observed important changes, in particular in the US, regarding trends in serum phosphate, which Murilo will cover in just a moment. And the ramifications of that we can speak to as well thereafter. Okay, so here we see less than 5.5, the majority of respondents, and that's fewer than 20% at less than 4.5 or less than 6. So quite a wide range indeed. I think a lot for us to talk about in the Q&A session. I think we're doing quite well. We'll move on to PDOPPS at the top of the hour. So we will have at least 10 minutes, perhaps 10 to 12 minutes or so for question and answer session after Murilo's talk. And again, feel free to provide questions through the question function. All right, thanks.
Hello, everybody. My name is Murilo Guedes. I'll be presenting you the results of our work on mineral bone disorders, biomarkers, trends, and practice patterns in the DOPPS study. It's a real pleasure to be here speaking with you all. So in terms of background for this study, it's important to recognize that mineral bone disorders in CKD and in hemodialysis patients in particular is associated with worse clinical and patient-reported outcomes. And this has been repeatedly demonstrated by several observational studies in different parts of the world. And yet practice patterns for mineral bone disorders, they vary globally. And one of the reasons for this variation is the absence of randomized controlled trials showing benefits in terms of clinical outcomes for pharmacological and non-pharmacological interventions in this area. We do have many observational studies showing or suggesting that specific interventions may improve patient outcomes, but there is a real lack of clear evidence for intervening in mineral bone disorders and impact on mortality outcomes or patient-reported outcomes in the general in-center hemodialysis population. Mineral bone disorders biomarkers trends across the world are important because as practice patterns vary in different regions, we can see or potentially evaluate different outcomes as a result of different policies or nephrologist perspectives in terms of targets for specific biomarkers or even preferences for different interventions in this area. And the DOPPS study, as being a cohort study, observational cohort study in different regions in the world, is well positioned to evaluate and describe the trends and practice patterns in this area in different regions. This was our objective here, namely describing trends in serum phosphate, in serum PTH levels, and also in different practice patterns in the mineral bone disorders area in in-center hemodialysis patients. So one of the key results that we found, and we'll be presenting soon at the ASN, is that over time, if we analyze the past 2 decades, so starting on 2002 and going all the way up to 2021, we tend to see that the US compared to Japan and Europe tended to have higher phosphate levels over time and different trends in serum phosphate indeed. So when we look at 2002, serum phosphate levels were comparable across different regions if we look at Europe, Japan, and the US. And yet over time, there was a increasing variation of these serum levels if we compare these 2 regions in 2021. So in general, the Europe trend was really a decline in serum phosphate levels over time, whereas in Japan, the trend was a bit more stable, resulting in phosphate levels around 5.3 in 2021. And in the US, we actually have 2 different and actually opposing trends. When we analyze from 2002 to 2013, we tend really to see a reduction in serum phosphate levels in this country, only to be completely reversed after this. So after 2013, going all the way up to 2021, what we see is actually an increase in serum phosphate levels in the US population. It's important to be reminded of that in 2009, KDIGO published one of the key guidelines suggesting that phosphate levels should be lowered towards the normal range in the dialysis population. So these results really, they are conflicting with the KDIGO guidelines because the average serum phosphate in the US in 2021 is above what is usually considered the normal serum phosphate levels. And if we do a deep dive into the US population and analyze different categories of serum phosphate levels over time, and if we assume that serum phosphate levels above 5.5 milligrams per deciliter would represent hyperphosphatemia, what we see is a real increase in patients with hyperphosphatemia in the US since 2013 until 2021. And this is well represented here by 25% of patients who have phosphate levels between 5.6 to 7, and even 17% of them would have phosphate levels increase above actually 7 milligrams per deciliter. And these trends, as already shown, have been increasing in the past few decades. When we look at the median PTH, serum PTH levels in these three regions, we also tend to see remarkable differences. As is well known, in Japan, PTH levels are lower than other regions in the world due to distinct practice patterns, and they remain pretty stable in the past 2 decades. As opposed to in Europe and in the US, in which both regions' PTH levels tended to increase. In Europe, starting in 2002 with 150 picograms per ml until 281 in 2022 to 2021, sorry. And whereas in the US, this varied from 200 to 373. It's interesting also to recognize that after the 2009 KDIGO guidelines, as it seems, PTH levels tended to start the uprising levels or the increasing trends after these guidelines. And it's important to mention as well that the guidelines recommended to maintain PTH levels in the range 2 to 9 times the upper normal limit. And this, one of the main speculations here, that the potential distinct interpretations of this statement by the KDIGO guidelines could have resulted in this, let's say, increased tolerance to higher PTH levels in the US. When we look at practice patterns, and all the data that will be presented in the next slides refer to US population. So when we look at different practice patterns, we don't tend to see a lot of variation. So phosphate binder use remained stable in the past few decades. The same for calcium mimetic use in the US, not a big variation. And also vitamin D analogs didn't tend to have a greater variation in the analyzed period. So practice patterns in the US didn't change as much. And what do we have in terms of new data coming and actually new interventions in this area? And this is summarized in this slide. I will briefly go over it. We have two main trials, the HELO and the phosphate trial. The HELO trial is an open label cluster randomized control trial, and the phosphate trial is an open label individual level randomization RCT. These studies will address whether higher phosphate targets versus lower phosphate targets have any impact in terms of clinical outcomes. These both studies have as a primary outcome all-cause mortality in the HELO study and phosphate trial major adverse cardiovascular events. And their results are expected by 2025, and they may reduce the practice pattern variations, at least in terms of treatment of hyperphosphatemia. So to wrap up, among in-center hemodialysis patients, phosphate levels tended to increase in the past decade in the US as compared to more stability in Japan and reduction of serum phosphate levels in Europe. The US trends, they do contrast with the KDIGO guidelines, at least for phosphate levels. And this may represent many reasons. One of them could be titration of phosphate binders to lower doses, meaning higher phosphate levels over time, or even could be that in the US, nephrologists or dietitians are recommending a more permissive diet. This is all speculation. We don't have data as yet on that. Important as well to recognize that distant practice patterns in terms of vitamin D analogs and calcium mimetics may explain the variation in PTH and phosphates. Important to remind that vitamin D analogs can increase serum phosphate levels through increased intestinal phosphate absorption. Finally, dialysis practice patterns like MOD filtration use could also contribute to the extended trends, as new data have been showing that HDF may reduce phosphate levels as compared to high flux HD. And finally, we don't know as yet the optimal phosphate targets, despite the consistent observational studies showing that higher phosphate levels associate with worse outcomes. Thank you.
Great. Ron, I'm not hearing you right now. Nonetheless, if you stay with us.
There. Okay.
Oh, good. Yes.
Good. Great.
Right.
Well, yeah, I'm sorry for the technical glitches here this morning. Everything was working fine in our checks before 8 o'clock, but it's one of those things. Got a great team behind us, but yeah. Boy, these were just three really great presentations. I think all the three areas are just so informative and really have a great set of questions here. Are all of our speakers here with us? Do you know, with Jinju and Angelo and Murilo? Hi, Murilo. Good morning. And there's Angelo. Good morning, Angelo.
Hey, morning, Ron.
And there's Jinju. Boy, it must be late evening. Hi. Yeah. Jinju, I just, it's just so impressive. All of the investigations that you and your colleagues have going on in China, and really interesting papers as well. And we're very excited to have the participation of China in DOPPS 8, the launch of CKDopps in China, and now the OPPUS study as well in China. And so I just had one question, and this is open to everyone, of course. And I was really found the real-world results on roxadustat use very interesting that you presented, now being about 9% in China, and it's more commonly prescribed in older patients, those having longer dialysis vintage, females, diabetics. It appeared to me patients who have lower baseline hemoglobin levels and baseline lower TSATs. But then also, I was curious to know why is it felt it's more commonly used in these patient groups?
Yeah, thank you. Yes, because these patients maybe they have a relatively worse response to ESA. So yeah, because hemodialysis patients, after all, they have to go to dialysis center 3 times a week. So most of them, may be likely to use ESA intravenously, since they don't have to remember to use the drugs, and they don't want to take extra oral drugs. So only the patient who are have a resistance to ESA, or have some other reasons, for example, hypertension or something like this, and they will accept roxa, since they have to remember to take the pills, and they already have lots of tablets. The burden is very heavy for them. Yeah. So.
Yeah. Well, thank you. Yeah, that's interesting. It's also interesting that it looks like for maybe most patients who are prescribed roxadustat, that they are also at the same time still being prescribed an ESA, though maybe it appears at a lower dose. Is that correct?
Mm-hmm. Yeah, right. Yeah, according to the preliminary analysis.
Yeah. Well, that's interesting. And I imagine all of this, is evolving over time, isn't it? As everyone becomes more familiar with using the HIF-PHIs and the responses that you see in patients, and and whether it'll be interesting to see as how things evolve and change over time. I was wondering if any of the other panelists have any questions for Xinju.
Well, a couple of things, Xinju. A really wonderful talk, and thanks again for all you do with us. It was interesting, at least very, very preliminarily, that we're seeing the use of roxadustat in prevalent dialysis patients, and certainly not limited to folks who are new to dialysis. So that was a really interesting finding, I think.
Thank you.
Yeah, and look forward to following that up further. And also, just as you noted, one position with the HIF-PH inhibitors, of course, will be that an oral therapy is advantageous for folks who are not on dialysis or using home dialysis, but not necessarily for those treated by in-center hemodialysis, where IV therapy may be, from a patient perspective, fairly straightforward. So really interesting point of view. The other thing I was going to note, I should two things. First of all, we do have our EPRO study in China that is capturing PROs among incident patients in China, with a focus really on anemia and its treatment, which will be very interesting moving forward. The other thing, Xinju, just to note quickly, you mentioned that mortality is in the range of 9.8% per year, 9% or so, on the lower side, as expected, and also that cerebrovascular events were among the most common causes of death. I found that to be very interesting. that will be more common, relatively speaking, than in some of the other regions.
Before we try to focus on the mortality and its risk factors, and we have had the manuscript, but it's rejected by some journals, and now we are revising the paper, and hopefully in the future we can report more detailed information for our patients. Of course, looking forward to DOPPS 8 data, and maybe we can compare in the patient groups now and almost 7 years ago, because lots of things have changed. The insurance policy, the medical insurance, and the medication affordability and availability, like some phosphate lowering drugs. Yes, lots of things we can do. Yeah.
Exactly right. Well, and for example, the percent of patients with hemoglobin less than 9, as I looked at the data a few weeks ago, markedly fewer patients have very, very low hemoglobin in China than say 7, 8 years ago, probably related to access to therapies, just as you alluded to. So there's much more for us to look at. I think, Ron, maybe we'll move on to the other speakers just in the interest of time.
I agree. Well, thank you, Jinju. Angela, we had a question here from one of the audience members, and that, which was, did you check whether the pruritus severity was also associated with the level of hyperphosphatemia or with the area under the curve of phosphatemia? I know this is an area of interest, in the community.
Yeah, that's a great question, and this was part of the analysis. We didn't have the time and space to include it in the presentation today, but we have looked at the association between itch and phosphorus levels. When we've done so in the past, in more of a table 1, we've seen a minimal association with high phosphorus levels and itch. We attempted the same analysis that we did for the longitudinal pruritus. If you recall the slide that we showed with the arrows pointing up and down, showing that as itch improved or worsened, sleep quality tracked closely with it. We did the same for several different labs, including phosphorus, and found that when itch changed, phosphorus still tended to remain the same. And so we found that there was actually minimal evidence that high phosphorus levels were associated with itch at baseline and longitudinally. And I think this goes against often prevailing wisdom that high phosphorus levels can cause itch. So at least in our observational data, we saw a minimal link between the two.
Thank you so much, Angelo. I have a lot of other questions or comments that I could bring here as well, but I see we only have 2 more minutes. But I think I just wanted to make the point as well that I believe from your presentation we can see how dynamic CKD-AP is, in this 1-year longitudinal analysis that you did. And wasn't it something like about 50% of patients experience being moderately to extremely bothered by pruritus at some point over a year? It's something like that, isn't it?
Yes. And certainly we've shown that it changes from year to year. So I think going back to the poll question about how often itch is measured, we've seen that when we assess it once per year, those patients that are bothered sort of in year 1 and year 2, it's 35 to 40% at one time point, and then at the next time point. But these aren't the same patients, and you see some patients whose itch has resolved, whose itch worsened, and so it just goes to show that infrequent or rare assessment of itch means you may not get the same patients who you think were bothered by itch 6 months ago.
Yeah, that's a great point. So I would think that if the care team is asking patients every 2 or 3 months, just with a single question, that over the course of a year, you'd probably find about 50% of your patients are being, you know, at least moderately to extremely bothered by pruritus. So I think provides another additional evidence for the value of routinely asking patients in this regard. Hey, Murilo, there's a question here for you from the chat. And how is the evolution of K2-V during the last 20 years in these three regions, Japan, Europe, and the US? Could the increasing trend on serum phosphorus levels lead to a lower K2-V in the US? And I don't know if you've had a chance to look at that in this work. I certainly know what the trends have been in K2-V in the US, but I was just wondering what your thoughts were.
Yeah, this is a great question, and thank you, Pablo, for bringing this, and Ron for emphasizing here. We didn't actually look at the K2-V levels for this specific work, but yeah, it's a very important point as adequacy can affect, you know, phosphorus levels over time. That said, and I think Bruce emphasized in the chat as well, looking at the DOPPS data over time, there doesn't seem to be a variation in K2-V levels across US and Europe in the past few decades to justify the varying trends of phosphate, particularly in the US after 2013 as we saw them. So although this is a quite important point, I don't believe that this is actually the key answer here for the different trends that we're seeing.
Yeah, and I would just note quickly, I mean, the use of hemodiafiltration, high volume HDF, is a big shift in the last 5 years, and now we're at over 50% in Japan, close to 50% in Europe. So there's just a ton for us to study in this regard, including influence potentially on serum phosphate levels, but also, of course, middle molecules. And actually in the US, the first equipment for utilization of HDF was approved by FDA within actually earlier this year. We'll see if that leads to any meaningful change in use of HDF in this country, but much to look forward to and study in this regard. We're really well poised to look at this. There's a ton of I mean, the data that we have are really fertile for research into utilization of HDF and its effects.
And Bruce, it'll be interesting to see, because in these comparisons between high flux AG and HDF, there's also, you know, a very comprehensive clinical trial program that would come up in the next couple of years. So I think the combination of real world evidence plus clinical trial would really bring a lot of answers in this area.
Exactly. Yeah, thanks, Roberto. A couple of big trials in Europe, actually, principally in Europe, which would be a great one in the UK and one in the continental Europe. Wonderful. As well as Marilla noted, the important clinical trials looking at serum phosphate levels, randomization to higher versus lower phosphate. The interesting thing I'll just note with phosphate and that randomization will be that essentially I think will remain an unknown. We randomize folks to, for example, phosphate less than 5 versus greater than 6 or 6.5. Ultimately, at the end of the day, unless there's a clear signal one way or another, it may not be clear. For example, if a level of 5.5, it may indeed still be optimal, which actually was what most of the audience suggested as their target in the poll that we had earlier. So, and that reminds you of the hemoglobin trials, where again, in the range between 9 and 11 or 9 and 12, there's still a lot of unknown, let's say between 9 and 12, about optimal levels for patients. With this said, we are indeed a bit past the top of the hour, so it definitely is time for us to pivot on to our PDOPPS session. Ron, thanks for leading this, and thanks so much to our speakers as well. And with this, we'll pass the microphone over to Jeff Pearl, tremendous colleague of ours who leads the PDOPPS study, and Jeff is at the University of Toronto. Jeff, go ahead.
Good morning, evening, or afternoon, everybody. My name is Jeffrey Pearl from St. Michael's Hospital, and it's a pleasure to speak to you today to open up the PDOPPS component of the autumn update meeting on achieving global impact. I want to thank all the funding for the PDOPPS programs to date. In specifically, I want to also acknowledge that public funding has been obtained by agencies in France, Thailand, the UK, and the USA. The PDOPPS program has now spanned across 8 countries, 466 sites, and over 23,000 patients. And as you can see here, we have recently launched the DOPPS Practice Monitor in PD, where you can find up-to-date information on PD practices and select patient characteristics in a US sample of patients. Other interesting ancillary projects have been the UK PD catheter study, which was awarded through Kidney Research UK to support data collection under key factors that impact PD catheter placement and outcomes in the UK. And the OPPUS study, which you'll be hearing a little bit about today, an ancillary study of PDOPPS, which was a 5-year study looking at factors that impact peritonitis and peritonitis outcomes and standardization of peritonitis definitions. The BioPD study, led by Raj Mehrotra, looked at genetic determinants of peritoneal membrane function, and led by Francesca Tittori, the EPOC study looked at a patient decision aid in selecting dialysis modality. This is the PDOPPS steering committee, and it's a pleasure to work alongside these amazing individuals across the countries that span PDOPPS, and it's just a pleasure to continue to collaborate with these individuals. Just to let you know about upcoming ASN, we've had 2 abstracts accepted for Kidney Week, data based on OPPUS, which you'll hear about today, and similarly, a variation in antibiotic administration. Similar information you'll hear today in Dr. Al-Salawi's discussion of OPPUS. And this is just a list of our recent published manuscripts, 6 so far in 2022, and this is a selection of up-to-date publications of our manuscripts. So on to the session. We have an exciting program for you today. Leading things off will be Professor Simon Davies, who will be talking about the international impact of PDOPPS to date. As I mentioned, Dr. Al-Salawi will talk about the OPPUS study and some insights from the OPPUS study. Neil from Professor Boudville from Perth, Australia, will talk about a different PET test of the relationship between pet ownership and peritonitis risk. And last but not least, Dr. Aga from the University of Toronto will talk about drain pain and its association with patient clinical and treatment characteristics. So without further ado, we'll be on to the program and hopefully have some time at the end for some discussion and questions. I hope you enjoy the program, and thank you for joining us today. Thanks, and I just want to acknowledge the fact that similar to the DOPPS program, we have data sharing with academic institutions, and you can see these are local institutions that have also contributed to PDOPPS data publication. So really exciting to see these centers emerge and local study headquarters. And I just want to take this opportunity to thank you, all of the sites that contribute to data collection for PDOPPS and make this program possible and the information you're about to hear today. So on with the program, and it's a pleasure to move on to Professor Simon Davies to talk about the impact of PDOPPS.
Thank you for joining this webinar for an update on the PDOPPS study. In the next few minutes, I'm just going to update you on some international findings of high importance that we've recently demonstrated in the PDOPPS study. So we know, of course, now that survival on peritoneal dialysis has improved considerably over the last 20 years, but technique failure, or what is now called transfer to hemodialysis, does still remain a problem. So the first things I'm going to look at are how technique failure fits or alongside survival and transplantation in the countries involved in the PDOPPS study, in particular US, Australia, New Zealand, Canada, UK, Japan, Thailand, and most recently Korea. So the first point I want to make is that time on therapy is not a function of the transfer rate to hemodialysis, and that's because we need to consider mortality, transfer to hemodialysis, and transplantation as competing risks with time on therapy. And here's a slide that summarizes this data. I guess the first thing to point out is that actually when you look at these different countries, the differences in overall outcomes, death or transfer, are really not significantly different between the countries. There's some slightly lower levels in Japan and in Thailand, which are really driven by, in the case of Thailand, a low technique or transfer rate to hemodialysis, which is probably a function of the fact that there's a relatively high death rate. And in the case of Japan, both of these things tend to be lower, but in particular, low death rate. But the thing I really want to point out on this slide here is that there's vast differences in transplantation rates in these different countries. And the way that pans out in terms of time on therapy can be shown in this slide here, which is really a cumulative event rate in the 6 different countries that we're looking at here. And the 2 outliers in this analysis are Japan, which has a low death rate, a high use of hybrid hemodialysis and PD, and an extremely low transplantation rate, giving it an overall median time on therapy of 3.2 years, whereas in the UK, there's a very high transplant rate, relatively low death rate, and that is, I think, the explanation for why there's a short median time on therapy. But as you can see here, the overall outcomes are not really that different. In this same analysis, we also looked at patient factors associated with death or transfer to hemodialysis. And you can see here, as you might expect, age is important, competing risk here. So age increases the risk of death, but reduces the risk of technique failure or transfer to hemodialysis. As you might expect, comorbidities are really important in terms of survival, with some effect on transfer rates to hemodialysis. And of course, as usual, a low plasma albumin is associated with worse outcomes across the board. And you can see here this competing risk effect of transplantation associated with a reduction in death rate. At the facility level, we really found very few things that really made a difference. I think that what I want to really focus on here is the use of routine multidisciplinary review, which on this multivariate analysis seemed to be the single most important thing in terms of preventing transfers to hemodialysis. So the second lesson I want to think about now is dialysis prescription and how that relates to these outcomes I've just been discussing. And the 2 things I'm going to discuss here are total clearances, in this case the KT/V for urea, and also the use of the CAPD and APD modalities. So first of all, it's important to point out that there are significant differences between countries. In particular, Thailand and the US tend to go for higher overall prescribed total volumes of dialysate. This is despite this is adjusted for patient size, which is partly why the effect in Thailand is so great. And you can also see that they also have tendency of less dialysis prescription occurring in Japan. For example, there's no use of APD, much less use of APD in Japan. So this gives a total distribution of total KT/V urea as follows by these countries. And again, what you can see is that the lowest dialysis doses are being delivered in Japan. The highest dialysis doses have been given in the US, with somewhere in the middle with the others. And as you can see, this really has no relationship at all to the subsequent outcomes on dialysis, both in terms of the survival and transfer rates, as I have just recently shown you. If anything, they tend to be best in Japan, where the dialysis prescription is least. What about dialysis modality? Well, again, there are important differences at a country level between, in terms of the use of APD, which is very high in the US, moderately high in countries like Australia, UK, and Canada, and relatively low in Japan and South Korea. So how does this relate to subsequent outcomes? Well, the first thing to point out here is that when you look at all countries together, there really is no significant difference. Whether you have APD or CAPD, the confidence intervals across the line. There's a suggestion that the longer time spent on peritoneal dialysis maybe is associated with a slight reduction in mortality, but an increase in transfer rates. But really, that is not significant. At a country level, we do see some interesting observations, which I think reflect patient selection. So interestingly, in the countries that are high users of one therapy, then it is the opposite therapy that is associated with better outcomes. So for example, in Japan, which has a relatively low use of APD, actually they have better outcomes in their APD population in terms of survival. But for example, in the US, where there's a very high level use of APD, there's a relatively better survival in the CAPD group. And that suggests that actually over selection of one therapy from the other is possibly not the right way forward, in that there are some patients who perhaps do benefit from one therapy rather than the other, and they're getting a selection effect on subsequent outcomes. For my final set of lessons, I wanted to think about some large country differences which I think generate testable hypotheses which we should look at in terms of understanding whether we could improve outcomes. And I'm going to focus on a couple of these. I'm going to focus on the plasma potassium levels, which are particularly low in Thailand. And I'm going to focus on ultrafiltration practices, the use of icodextrin and glucose to drive ultrafiltration rates, which are different to other countries when you look at the US data. So here we see the data on potassium, and you can see that Thailand is a definite outlier here with a very high portion of people with a potassium of 3 millimoles per litre or less, which is associated with worse outcomes. And this is the survival and data from this study. And again, it shows that low potassium levels are associated with increased risk of death. And interestingly, the more persistent that low potassium level is. So if you look on the right-hand side here, you can see that if you have 4 measurements of potassium that are low over a 4-month period, then that's associated with even worse outcome than just an occasionally low potassium. So persistent hypokalemia is associated with worse outcomes, and something fairly similar is seen with peritonitis, although it's interesting it's the gram-positive peritonitis, not the gram-negative, as has previously been suggested by other studies. What is the explanation of this? Well, we think it's largely associated with nutrition. So what you find fairly consistently is that a low potassium is associated with worse nutritional parameters on laboratory testing. But there are also some practice patterns that are associated with that. In particular, you can see that it's associated with, for example, the use of loop diuretics. The use of RAS inhibition reduces the chances of hypokalemia, and a high peritoneal clearance is associated with an increased risk of hypokalemia, whereas having residual kidney function protects against this. So that obviously leads to some testable hypotheses which could be done. And indeed, there are studies now going on in Thailand to look and see whether supplementation of potassium or other approaches might have an impact on outcome. And finally, I want to discuss ultrafiltration or fluid removal on dialysis. Back in 2020, when we did our first survey of practice patterns, we were interested to observe that there's a relatively high use in the US of middle strength and hypertonic glucose exchanges reported, with up to 40 or 50% of people using 386 exchanges and a very low level of patients using the low glucose concentration, strongly different to other countries, for example, Japan. And this seems to be associated with the very low use of icodextrin in the US. Again, a clear outlier when compared to the other countries where icodextrin is available. So we did a more complex analysis of this. We wanted to understand who was getting icodextrin and how this related to outcomes. And we definitely demonstrated in this study that icodextrin is preferentially used in patients who are higher risk for example, have more coronary artery disease, diabetes, worse residual kidney function, and importantly, also in patients who have worse membranes for ultrafiltration, patients with high solute transfer rates, shown here with a reduction in ultrafiltration associated with that. The problem we had, however, that was membrane function was only being measured in 10 to 15% of patients within the time period of this study. And indeed, when we look at the approaches that different countries have for doing membrane function tests, we found this was quite different, with relatively low membrane function testing happening in the US. And indeed, there is a relationship here between the use of icodextrin and whether or not membrane function tests are done, something that was also observed in the ANS data study. So how does this translate into ultrafiltration? Well, this is country level again, showing that relatively high ultrafiltration levels are obtained in the US. You can see here that's higher than other countries, despite the level of residual kidney function. And when we looked at the use of icodextrin, we found that actually the icodextrin itself did not really impact on the total amount of ultrafiltration achieved. This was really driven mostly by the high use of glucose, particularly in the US. When we looked at survival and outcomes, I've told you that icodextrin was preferentially used in high-risk patients, which do have an increase in mortality. But when you adjust for that, then the use of icodextrin does not change mortality rates. What it does, however, do is change the use of glucose. So just to conclude this short talk, I think what I've demonstrated is that there are a number of important high-level things to take into account when thinking about outcomes in peritoneal dialysis. Prescription practice does vary quite widely. We've demonstrated yet again, if this was needed, that there's really very little association between small solute clearance on PD and survival. Again, that really confirms the findings of the ADAMEX study. And using CAPD versus APD, again, broadly similar outcomes are observed. And I would suggest that this suggests that if both are available, then they should be used according to patients' preferences rather than to achieve a particular prescription goal. The exception to that might be membrane function, but that's not something we've been able to answer in this study. Low potassium is an important risk factor, but it is modifiable, and so potentially if nutrition could be improved, then that should be something that could be done to improve outcomes on dialysis. And finally, we can see that icodextrin is used preferentially in high-risk patients with a reduced requirement for glucose and high glucose prescriptions. But this issue of high ultrafiltration levels need to be investigated further. Thank you for your attention.
So much. It's my pleasure to be with you today in the annual DOPPS program meeting to provide some updates on one of the OPPUS studies that aim to standardize peritonitis reporting in the States. So this project was supported by a grant from the USAHRQ, and the full list of DOPPS funding can be provided here. So peritonitis is actually a very concerning infectious complication in PD patients. And despite the advances in peritonitis prevention and treatment, it has actually remained the leading cause of modality switch among all countries enrolled in the PDOPPS. Now, although there is a national surveillance system in the US for catheter-related bacteremia in hemodialysis patients, no similar formal mechanism exists for the reporting of PD peritonitis. So the objective of this OPPUS pilot study is to develop a uniform wide-scale peritonitis reporting mechanism and to evaluate its implementation in a diverse cohort of US PD units participating in OPPUS study. In terms of methods, after reviewing the literature, the ISPD guideline, and consulting the stakeholders, a web-based peritonitis tracker tool was developed by Arbor Research. 52 PD facilities were selected based on geography and reported peritonitis rates. Formal training, central data review was provided, along with education of all peritonitis episodes and outcomes. So basically, a staff at each participating facility was recruited, typically a nurse, to record peritonitis details into a secure web-based data collection platform that was created by Arbor Research. Coming to the results, we had a total of 442 episodes in 391 patients. The median month of facility participation was 12. The median facility size was 36 patients, and the overall peritonitis rate was 0.23 per patient year. In terms of outcomes, 41% of episodes were associated with hospitalizations, 17% of episodes resulted in hemodialysis transfers, with the majority being a permanent transfer. In terms of mortality, around 6% of episodes resulted in death, and 18% of episodes resulted in PD catheter removal. This slide showed the number of episodes by the causative organism. Around half of episodes were gram-positive, surprisingly followed by culture-negative peritonitis, which was as high as 22%, and we'll discuss the potential reasons of high culture-negative later in this talk. So all facilities indicated routine recording and tracking of peritonitis episodes by different methods. The most frequent way of data extraction was from a third-party electronic health care record, like EPIC, for example. All facilities indicated meeting routinely at an interval of 1 to 3 months to review PD-related infection rates. And the multidisciplinary team involved in this process included a medical director in all facilities. Only 30% of facilities included non-medical director physicians. 3% included microbiologists or ID specialists. And interestingly, none of the facilities involved a pharmacist in this review process. Here we ask the unit about the method of obtaining effluent cell count when patient presented with suspected peritonitis. Now, although most facilities were doing the proper timing for effluent to dwell before cell count, which is 2 hours as suggested by ISPD, not all were doing the proper volume. As we can see, around 42% of facilities were doing less than 50 ml, while the ISPD suggests a minimum of 50. This slide shows the average turnaround time from when the cell count are obtained to when the results are available. Interestingly, the average turnaround time was more than 24 hours in 44% of the facilities. And this could potentially explain how most facilities indicated having no access to PD effluent cell count before the initiation of treatment. In terms of home antibiotics, 75% of facilities provided patients with antibiotic to keep at home and to self-administer when peritonitis is suspected. Now, this approach can actually help in early administration of antibiotics, which is a critical part of peritonitis treatment. It can, however, increase the risk of culture-negative peritonitis when antibiotics are administered prior to obtaining the effluent culture. This slide shows the empiric choice of antibiotics for peritonitis treatment. I just want to point out here that around 40% of facilities do not routinely check vancomycin levels when prescribed. In terms of administrations, majority were giving the antibiotics intermittently, like in one exchange per day. For dose adjustments, 75% adjusted doses by weight, and only 47% adjusted doses by residual kidney function. Now, keeping in mind that most of the antibiotics we use for peritonitis treatment are excreted by the kidneys, meaning that patients with substantial residual kidney function might clear the antibiotic faster in the urine, which ultimately might lead to subtherapeutic levels. Now, the ISPD guidelines, the recent ISPD guidelines suggested to increase the dose of cephalosporin by 25% in patients with substantial residual kidney function. In terms of the site feedback on this tracker tool, peritonitis tracker tool, around 80% expressed their interest in continuing the participation in the study, with 83% recommending the OPPUS tracker tool to other clinics. So moving forward, the next steps we believe are to implement this peritonitis tracker tool in a wider scale to develop a national system for peritonitis reporting and tracking. And also to evaluate the impact of different peritonitis preventive and treatment strategies and adherence to ISPD guidelines on peritonitis rates across PD clinics. So to conclude, standardized and uniform peritonitis reporting is feasible. Valuable insights can be gained, which can allow for benchmarking, outbreak identification, and the implementation of different quality improvement initiatives. That would be all for me. Thank you so much.
Hello, I'd like to thank the ARBO Research Collaborative and the PDOPPS team for inviting me to give this talk today on some of the research that we're doing. Today's talk is titled A Different Pet Test, the relationship between pet ownership and the peritonitis risk in PDOPPS. In the United States, 64% of homes have dogs or cats. As a home-based treatment, PD patients run the risk of developing zoonotic diseases from their pets, and as such, the 2016 International Society for Peritoneal Dialysis guidelines recommended that domestic animals should not be in the area while PD exchanges are being performed. Pets may be associated with an increased risk of peritonitis either directly via transmission of zoonotic organisms during close contact or indirectly by posing a distraction while attempting to perform aseptic technique during PD exchanges. Indeed, a French registry found that 0.5% of their peritonitis episodes were indeed due to zoonotic organisms. The most common zoonotic organism causing peritonitis associated with pets is Pastorella. This is a gram-negative aerobic coccobacillus which is found in the upper respiratory tract of many animals and on the claws of cats. The majority of Pastorella PD peritonitis episodes were associated with cats, and the mode of transmission was thought to be either due to biting or clawing of PD tubing or PD bags, contamination of the automated peritoneal dialysis machine by the pets playing near or on it, or by the patient having close contact with the pet leading to contamination during a PD exchange. However, there are various other pathogens that are shed from the feces of pets, especially those fed raw meat or bones, and then transmitted to humans, causing infection. Moreover, there are human pathogens that commensally live on pet skin and fur that can be an additional source of infection. The primary aim of this study was to see how common it was for PD patients to have pets and to examine the association between pet ownership and peritonitis risk within the PDOPPS study. PDOPPS is an international prospective cohort study of adult PD patients and has recruited a representative sample of PD patients across 8 countries, including Australia, Canada, Japan, New Zealand, South Korea, Thailand, United Kingdom, and the United States. Informed consent was obtained by all patients, and patient demographic and comorbid conditions were collected at study enrollment, and there were included within this some questions on household pets. Peritonitis episodes were collected using uniform standardized data collection tools, and the risk of peritonitis was modeled using Cox proportional hazard regression, stratified for prior peritonitis episodes during the follow-up period. In total, 3,655 PD patients provided information about household pets, out of a total of 4,473 participants who filled out the patient questionnaire, and a total of 12,447 eligible patients. Among the patients who reported on pet ownership, patients indicated owning only dogs 19% of the time, only cats 7% of the time, and 6% had dogs and cats. Most countries, including the United States, had less than 50% of the PD patient households having pets, which is lower than the US general population. Notable differences can be seen between countries in the profile of pets at home, including low numbers of pet ownership in South Korea and greater numbers of cats than dogs in the United States, Thailand, Japan, and the United Kingdom. Thailand was also distinguished by a large portion of households having pets that were neither cats nor dogs, but instead included farm animals such as chickens, geese, ducks, and cattle, and these were excluded from the analysis. The average age of this cohort was 59 years, with 57% being men, and a PD vintage of about 24 months. Over the median follow-up of 14 months, there was a total exposure time of 55,475 patient months, in which time 1,347 peritonitis episodes were detected, with an overall peritonitis rate of 0.29 episodes per patient year. Comparing various combinations of pet ownership to PD patients with no pets as the reference group, there was no appreciable difference in peritonitis risk overall, with any pet ownership being associated with a hazard ratio of 1.09 and 95% confidence intervals of 0.96 at 1.25 adjusted. However, patients who own both cats and dogs experienced an elevated risk compared to patients without any pets, with a hazard ratio of 1.45 and a 95% confidence interval of 1.14 to 1.86. When we explored the effect of patients living alone, no difference in the association between pet ownership and an increased risk of peritonitis could be identified. Overall, there were 3 episodes of peritonitis due to commonly reported pet-related zoonotic organisms. The limitations of this study include the lack of detail of the actual interaction between the PD patients and the pets. In addition, we do not know the number of pets per household. It is possible that the increased detected peritonitis risk associated with having both dogs and cats is due to the presence of having more than one animal in the household, rather than being due to the different species of animals. Finally, not all of the PDOPPS participants completed the survey to be included in the study, but peritonitis rates were no different between those that did and did not complete the survey. Utilizing this large cohort study, our results suggest that no increased peritonitis risk with pet ownership was seen, except for those that had both cats and dogs. It is conceivable that the number of pets may be an important risk factor for peritonitis, and this information may be helpful for patients and their PD care team who may wish to devote specific attention to this issue during training. While pets within the household of PD patients appears to be relatively common, it may indeed be less common than the general population, suggesting that some patients with pets may opt out of doing PD for this reason. While it would be prudent to ensure maintenance of a high level of hygiene during a PD exchange Our results suggest that pet ownership should not be an obstacle for choosing PD. Thank you.
Hi everyone, my name is Xenia. I'm a home dialysis fellow at St. Michael's in Toronto, and today I'm really excited to present our result on peritoneal dialysis drain pain. So what is PD drain pain? Well, much like the name sounds, this is pain that occurs during the outflow of PD effluent from the peritoneal cavity. And it's really felt to be a consequence of negative pressures being applied to these very sensitive intra-abdominal tissues. Drain pain is an important issue for PD patients because it can contribute to poor sleep and poor quality of life. It can cause patients to terminate their treatments early, and in severe cases, patients may discontinue peritoneal dialysis entirely as a result of this pain. But despite this being an important issue for PD patients, there are no large multi-center or international studies assessing the prevalence of drain pain. So this brings us to our study. Our study had two objectives. Firstly, we wanted to determine the prevalence of peritoneal dialysis drain pain in a large international cohort. And secondly, we wanted to determine the patient and treatment characteristics associated with having drain pain. Our study consisted of 1,626 PD patients from 134 facilities across 5 countries, and these patients completed a questionnaire answering 2 questions. Firstly, it identified whether or not patients had drain pain in the preceding week. And secondly, the patients were then asked to rate their pain on a scale of 0 to 10, so a Likert scale. We subsequently performed a multivariate logistic regression to identify the patient, catheter, and treatment risk factors associated with having any drain pain, as well as a secondary analysis of severe drain pain, defined as having a score of 5 or greater on the Likert scale. So to take a quick look at our study population, the average age was 60 years. The patients were on peritoneal dialysis for a mean of 1.7 years. And in terms of the differential distribution of APD and CAPD, 41% of our patients were on automated or cycler peritoneal dialysis, with the majority being on ambulatory PD prescriptions. So now let's take a look at our results. So drain pain in the preceding week was reported by 28% of patients. So almost 1 in 3 patients reported having drain pain in the preceding week. And of these patients, 35% then went on to grade their pain as severe. Now, by extending our results beyond North America, we were also able to find differences in prevalence of drain pain by country. So if you take a look at this figure, you can see the greatest prevalence of drain pain in the UK, 47%, with the lowest prevalence in the United States, 24%. Now, this variation may be influenced by differences in sample size, differences in survey response rate, and one could wonder whether there may be subtle differences in PD or APD technology as well as prescription that could have influenced differences in drain pain incidence among different countries. So here's our table 1, illustrating the presence of drain pain in the preceding week across various patient treatment and catheter characteristics, and highlighted are some of the variables that were unequally distributed between the two groups. However, I'd like to focus on these results of our multivariate logistic regression. So firstly, incident PD patients, so patients who had been initiated on peritoneal dialysis within the last 3 months, had a higher odds of having drain pain, with an odds ratio of 2.42. Now, this phenomenon may be a result of new PD patients simply needing more time to adjust to the new sensations of peritoneal dialysis. Secondly, patients with polycystic kidney disease also had an increased likelihood of having drain pain, with an odds ratio of 2.96, so they almost had a 3 times greater likelihood of having drain pain. This may be the result of the large kidneys simply causing a fullness sensation, but also it may increase the likelihood of the PD catheter hitting sensitive intra-abdominal tissues. It really begs the question as to whether there should be specific pre-dialysis education about the possibility of drain pain upon PD initiation for this particularly high-risk population. Now let's take a look at those who had a lower odds of drain pain. So firstly, patients who were age 75 or greater, males. Now it's unclear why there was a higher prevalence of drain pain in females. But one potential explanation for this observation could be in pelvic anatomic considerations. So for example, perhaps the PD catheter becomes pushed against the uterus, causing pain through applying negative pressure during draining. Now, although it didn't reach statistical significance, there was a trend towards less drain pain in those with laparoscopically inserted catheters. Now, this may be explained by the benefits of having direct visual inspection during laparoscopy, but additionally, adhesiolysis and omentectomy all may improve the positioning of the PD catheter and may prevent it from having contact with very pain-sensitive pelvic tissues. Lastly, there was a trend towards less drain pain in patients with straight-tipped PD catheters, and this certainly adds to the previously observed lower rates of infusion pain that was demonstrated in a randomized controlled trial by Chow and colleagues. And it's certainly tempting to speculate that this finding may be the result of reduced likelihood of a straight-tip catheter being hooked onto sensitive peritoneal surfaces. Not surprisingly, patients who were using automated PD or APD had a higher odds of having drain pain, with an odds ratio of 1.82. And the rationale behind this is that contemporary cyclers use a hydraulic suction instead of gravity, which could apply more of a negative pressure to the sensitive parietal peritoneum or bowel wall. Though this brings an important point, which is that kidney care practitioners should consider using CAPD prescriptions in the high-risk period for drain pain among those newly started on PD, but also in patients who are at risk of drain pain, such as polycystic kidney disease patients. Surprisingly, among APD patients with drain pain, only 40% were treated with tidal PD prescriptions. And as we know, tidal peritoneal dialysis is one of the only and one of the most effective ways to manage peritoneal dialysis drain pain. And so this really highlights a missed opportunity for therapeutic intervention. Lastly, constipation and abdominal surgical history, in fact, did not increase the odds of having drain pain in our study. So this is our forest plot simply illustrating the results that I mentioned. In conclusion, this is the first large-scale study to assess the prevalence and risk factors of drain pain, which shows us that not only is drain pain common, but particularly in the first 3 months of treatment. Kidney care practitioners can consider using laparoscopic catheter insertion and straight PD catheters, particularly in those who are at high risk of drain pain, such as those with polycystic kidney disease. And similarly, we should consider using ambulatory PD prescriptions in those who have established drain pain, those who are at high risk, such as females and those with PKD or incident PD patients. Lastly, our results highlight a missed opportunity for intervention, as we saw that only 40% of patients with drain pain on APD were treated with tidal PD prescriptions. We hope that these results will help in development of a questionnaire that can be used in routine clinical practice to identify those with drain pain. We'd like to in the future evaluate differences in drain pain by different APD technology. And lastly, we hope that our results help to fuel more knowledge translation about the role of tidal PD in managing drain pain. So I'll stop here. Thank you to everyone for listening, and I'll open it up for questions.
Thanks, everybody, for fantastic presentations. We'll just wait for the panelists to come on live. Great. Thank you all for doing such a fantastic job. I'll just remind everybody to please feel free to submit questions in the chat, in the question box, and we'll do our best to answer as many as we can live. And so maybe we'll start off with you, Simon. Simon, what do you think one of the more important prescription practice changes that we can learn from PDOPPS that we could potentially apply to our patients right now might be from the data that you presented? And I know that there was quite a lot, but anything that strikes you as something that might be more readily actionable?
Just unmute myself. I mean, I think I'm still struck by this variation in ultrafiltration practice. I don't think we've got to the bottom of it yet, so I perhaps can't tell you exactly what we should be doing. But it strikes me as very odd that we are in some countries using driving a lot more ultrafiltration than others. It doesn't seem to be associated or explained by levels of residual kidney function. You know, I think there are important differences there to tease out. I would also emphasize the lack of membrane function testing that we've seen in the PDOPPS study, which is clearly, I think, a lost opportunity in certain situations where people could be using icodextrin more frequently. Otherwise, I think the general message that comes out of all these observations is that you know, there's more than one way to prescribe your PD, and really the fundamental thing should be think about the patient, think about their lifestyle, how can you best accommodate that, and then use the therapy and the way in which just to support that. So I think that's the main message, but there are some things there that I don't think we fully understand and need teasing out.
Yeah, and I think one of the things that you mentioned in the talk that I want to highlight is, I think in PD, we tend to have more challenges with hypokalemia than hyperkalemia. And we certainly found an increased risk of enteric peritonitis. And I know Roberto put in the comment section a follow-up randomized controlled trial, which I think is great. You know, it's really exactly how it should be. We have observational data where we see an association, and we know in Thailand, there's a high prevalence of hypokalemia, substantially more than the other PDOPPS countries. And they actually followed that through with an intervention to be more vigilant about K supplementation with a demonstration of reduction in peritonitis. So I think it's like a great example of how research should naturally evolve for hypothesis generation and looking at patterns, and then actually implementing an intervention based on those. So I think it's really great. And I think for me, it's definitely made me more heightened about being more vigilant around potassium. And rather than saying, we'll repeat it again the next clinic and see what's going on and eat another banana type of thing. I think
I agree with that, Jeff. It's actually one way it's changed my practice is that when we have a patient with a low K, what we used to do was treat them with 5 days worth of potassium, then recheck the potassium. And of course, it got up a bit, and then a month or two later, they would recheck it, it was low again. So we've actually changed the way we deal with that. What we do now is we give them basically a low-grade amount of potassium all the time.
Yeah,
this is and then safe to do. The other thing you can also use is
Yeah, no, I think it's really interesting. And the other thing I was thinking about, with just going back to your fluid point, if you go to the US and you go to a convenience store and try to buy a Diet Coke versus you go to the UK or other countries, big volumes. So to what extent do you think the ultrafiltration differences are driven by, and I know we don't measure this and it's hard to measure, by differences in actually culturally and in fluid intake?
So my strong guess actually is that it is what we are observing actually, probably with the potassium issue too, is cultural things that are going on in terms of dietary habits, or as you say, high volume drinks, perhaps with a lot of glucose and stuff that drives thirst in them. And I think it's interesting also that we should remember that in the PDOPPS population, that the US patients are the heaviest patients in the study too. And one can't help but think that all that glucose is perhaps not the best thing for that group of individuals to be doing. But as you say, it's a high level cultural thing, perhaps more than something we can easily answer in the PDOPPS study, but perhaps it doesn't stop us from changing practice.
Yeah, no, I think that's really insightful. And I think people are using the opportunity to, Simon, to ask you all things peritoneal membrane. So we might be a bit divergent here in the question, but nonetheless, I will ask it anyways. And I just want to remind everybody that PDOPPS is done in collaboration with the International Society for Peritoneal Dialysis. If not already, please consider becoming a member of the ISPD with access to PDI. And the reason I say that is because this question, can SGLT2 inhibitors prolong membrane longevity? Simon, we'll just pick your brain about that. I want to tell you that in an upcoming issue of PDI, we're going to devote a lot of space to talk about SGLT2 inhibition, which is clearly on everybody's mind in every domain of CKD care. So maybe, Simon, you could just briefly comment on that if you can.
Well, the first thing to say is that, as you say, it's a powerful group of drugs which seem to improve outcomes in ways we don't fully understand. But it seems that if you've got, certainly as PD patients have some residual kidney function, it does seem to be very likely that this group of drugs could have good outcome, real benefits for PD patients. I think that's worth saying right from the start. I think the more specific question, which is around whether or not the SGLT will protect the membrane, I think it's a bit more difficult to answer that. I think the argument would be that it might stop glucose uptake by the peritoneal membrane, and then that might therefore mean you don't need to use so much glucose in the long run to get the same amount of ultrafiltration. At least I assume that's what's being asked here. There is some experimental data, I think, which suggests that it's more gluten inhibitors that might do that. But at the moment, but even that, I think, is fairly provisional data, because the rate at which glucose is absorbed across the peritoneal membrane is really best predicted by diffusion and characteristics of the membrane. So I'm a little bit surprised to find that blocking even glut could have, at least in chronic use of glucose. It might work in an acute situation, let's say in an animal model, but I'm not sure that it would necessarily work long term in a patient.
We'll have to leave you for those thoughts to maybe consider an editorial in PDI on that. Putting you on the spot. All right, we have got a few more minutes for some rapid fire questions. Neil, that was a really insightful presentation as well for most of us who actually have pets. What advice do you give your patients who are starting PD who do have a pet at home? And so does this mean it's a free-for-all, all pets, everybody, no concerns? Or sort of what caveats would you put to the data that you provided?
Can you hear me? I'm not sure if you can.
Yeah, we can hear you great.
So look, that's a great question, Jeff. And I think that the problem that the PDOPPS suggests is that maybe people who have got pets are avoiding PD, or maybe those who have pets are, getting rid of their pets because the pet utilization seems to, or the pets at home seems to be at a much lower rate than it is in the general population. So I would suggest that pets should not be an obstacle. I did this study because I have a cat and a dog that I love and adore, and I can't imagine not having.
You're a cat and dog person.
Yeah, I'm a cat and dog person.
So you're an increased peritonitis risk.
But I don't think it's an obstacle. I think good care, vigilant care at the time of exchange is the key thing. I mean, I think the limitations that PDOPPS impose on us were we don't know the level of connection or connectivity between the pets while the patient is doing an exchange, and the sheer number of pets that the patients have got. So maybe they are factors, but it shouldn't be an obstacle. And pets obviously give you a lot of other benefits that maybe we haven't quantified clearly in PDOPPS.
Yeah, and I think for people that tell their patients to get rid of pets before PD, I always say the patients will get rid of you before they'll get rid of the pets because they're such an important part of their family. The only thing I would add to that is I sometimes tell people not to do the exchanges in the room with a pet at the same time. And cats are notorious for, biting and pulling at things. So sleeping with a pet might be a higher risk situation. And of course, we didn't ask that question in terms specifically, but it'd be something to think about, not letting pets sleep in the same bed as you, for those of us who have done so. Moving on to Xenia, that was a great presentation and really so proud of how wonderfully it was delivered. Where do you think our next steps are for this? So where do we take this information and how do we move forward with it? Because it clearly identifies an issue that I think all of us as clinicians sort of recognize and appreciate, but maybe feel a little bit helpless in terms of, what to do with this information and where to go from here. So what are your thoughts on that? Oh, I think are you frozen?
Oh, okay, I'm unmuted now.
Oh,
Thank
good.
you for the question. So I think there's a couple of different directions. I think one thing is just seeing how common drain pain was, like almost 1 in 3 patients. The first step would be, making sure that we are identifying all the patients that do have drain pain. And I think very early in their course, it is something that we naturally ask a lot, as clinicians, are you having pain during draining? But we may that may trail off, and I'm not sure how frequently it's assessed kind of later on in their PD trajectory. So, it brings up the question of should we have a validated questionnaire as a first step that we can use for PD patients in their routine clinic assessments to make sure that we don't miss the patients that do have drain pain, where we could be implementing interventions such as changing them to ambulatory PD prescriptions or, APD adding in tidal, for example. So that's one thing I would say, is creating kind of a questionnaire that's maybe validated to assess and quantify the severity of drain pain that patients are having. And I wonder, there are kind of next steps in terms of transitioning these results in the clinical sphere is really comes in the way of the movement incremental peritoneal dialysis, because we are seeing that drain pain is more common in those newly started PD patients. We're also seeing that ambulatory PD prescriptions are less associated with drain pain. So perhaps there's also more of a push towards the movement of incremental dialysis, where you would be using ambulatory PD in those particularly high-risk patients who are newly started on peritoneal dialysis. And lastly, I'll quickly say, I think it's perhaps we could create some sort of, for physicians to go through when they're implementing someone on peritoneal dialysis to assess their risk of having drain pain. So, for example, are they female? Do they have polycystic kidney disease? Do they have a laparoscopic versus a percutaneous or IR guided? And then maybe for those patients, consider the following. So consider using ambulatory PD, or consider using a prescription from the get-go. So those are some of my preliminary thoughts.
Great. And then that was really fantastic. And then Muthana, thanks for a fantastic presentation. A really short question for you. I think a controversial area that you touched on is vancomycin level monitoring. One, because we don't know how often to monitor it. And number two is we don't know the prognostic significance of the levels. Can you comment on what your practice is and your thoughts around this area? Because I know it's really a challenging issue.
Yeah, thank you, Jeff, for bringing this up. Actually, vancomycin levels monitoring is is a challenging area because the evidence behind it is not great. Although it is generally recommended to monitor vancomycin and keep the levels above 15. And this is based on few observational studies, actually, that have shown that subtherapeutic levels are associated with higher rates of peritonitis relapse. So the general, I think even in the ISPD guideline, they are recommended keeping levels above 15. So personally, I find vancomycin levels monitoring an important part in peritonitis treatment, and I definitely do it at my units.
Great, thank you. And I want to thank everybody for doing an absolutely tremendous job today. Lots of information, and hopefully we'll continue to be able to disseminate our findings from both PDOPPS and OPPUS in upcoming webinars. So thanks all for your participation, and I think we're going to move on to the next part of the autumn update meeting.
Thanks, Jeff.
Yeah, thanks, everyone. Jeff, thank you so much for leading us and for your leadership at PDOPPS. Just so exciting, incredible, really the patient-centered focus that came through. It's really remarkable, and the work that's being done here through you and colleagues with PDOPPS is just so exciting. Okay, we'll move on now to the last segment, which is CKDopps, our study of advanced CKD. Roberto Pecofijo will lead and moderate this session, and we are well on time to finish up just before the top of the next hour. Again, as always, we look forward to questions and input from the audience. Thanks.
Right, and thanks so much, Bruce. And it's been really an exciting section. I'm enjoying that very much. And this is the last hour now, started now, with dedicated to our advanced CKDopps. So we have a very exciting session here, but I will start by just providing you a high-level update of how CKDopps is going. So at the moment, we have 5 participating countries with over 150 sites and more than 11,000 patients with CKD. The study is ongoing in the US. Follow-up is ongoing in France and Germany. Japan is organizing data for initiation of participation together with the other countries, and Brazil is planning the launch of phase 2. We are planning the transition to phase 3 in the US, or aligning and harmonizing this with data collection in our European collaborators and also in Brazil. Just wanted to highlight that the study is actually collaborating with organizations like CKD in France, and the DN in Germany, and REACH-J in Japan. So here's to acknowledge our wonderful country investigators that has put a lot of effort into data collection, organization of the research agenda. So here are the names of our colleagues in Brazil, France, Germany, Japan, and our internal team dedicated to CKDopps. I wanted to also highlight that I co-chaired the steering committee with Benedict Stengel from France. And there is a very comprehensive organization of our research working groups that meet regularly just to organize the agenda and to define priorities for research. And what you would see today actually is a result of this collaborative work with all these wonderful colleagues that I showed in the previous slides. So we do have more and more data sharing activities with academic institutions. I'm just bringing you some of the 2 very active examples. There is a data hub in France, based at INSERM in Paris, that we share data with the Renal Epidemiology and Information Network, again, led by Benedict Stengel. There's also been work done in collaboration with universities in the US with transfer of data. We'll hear more about one example of that later on. And we're very happy to see now some ancillary studies being approved by funding agencies. And you have a list here of 3 studies that receive external funding in competitively funded awards. One we'll hear today about conservative management practice in the US, which is funded by an IDDK 23 award. Another one, an award given by NKF to young investigators, will be presented here today. And finally, Manfred Hacking has received an award from Austrian funding agency to support some of the published data for CKDopps. Well, this is the program for today. I think we have an exciting program in the next hour. We will have a good amount of time at the end for questions and answers. But without further delays, I'm just gonna get the program started with the our first presentation. And I'm gonna start again with a poll question to prepare for that. So we have a question for you, and that is a question about the fact that you noticed or not in your clinical practice an improvement in kidney function after a vascular access is placed. So we're asking you to provide your views on that, if you have noticed that frequently or just rarely, or perhaps you didn't. I think it'll be interesting to hear your thoughts about this, because this is what we are gonna hear from our first presenter. So if first we could maybe take a look at the results. So it's really interesting to see that, although not very frequently, but some of you have noticed, half of you have noticed that in some cases, there's been a change in the trajectory of GFR after vascular access creation. And that provides, I think, a very nice background for our first presentation. So I'm going to invite Dr. Abdelhai Tabek from France. Abdelhai is a physician and has worked with public health in France, and more recently studied in a PhD program at the CKD group, and he's going to provide us an overview of his work that is going to be presented at the ASN Kidney Week last week. Let's hear from Abdelhai.
My name is Abdelhai Tabsh. I'm a medical doctor with a master's degree in public health, and I'm currently beginning my first year of PhD in clinical epidemiology. So first, I would like to thank you for giving me the opportunity today to show you our work on kidney function trajectories before and after arteriovenous access creation in patients with non-dialysis chronic kidney disease. So to introduce the subject, chronic kidney disease manifests by a progressive decline in kidney function and affects more than 800 million people worldwide. In some cases, chronic kidney disease can progress to kidney failure and therefore requires the initiation of replacement therapy. And in this presentation, we will focus on hemodialysis, which is the most used modality of kidney replacement therapy in the world, with approximately 2 million people, but more precisely on a very specific type of hemodialysis vascular access, the arteriovenous access, which is frequently used and includes fistulas and grafts. One of the main advantages of this access type is that it is very well tolerated by patients in the long term. Its main drawback is that it needs to be anticipated several weeks before the scheduled start date of hemodialysis. And this is where a big part of the problem resides, since on the one hand, it is really difficult to predict the evolution of kidney function decline during the transition period, kidney replacement therapy. And on the other hand, some observational studies have shown that the arteriovenous access creation could have itself an impact on the progression of chronic kidney disease. And these studies have consistently shown an attenuation of the slope of kidney function decline as expressed in terms of eGFR, ranging from 1 to 5 milliliter per minute per year. Several pathophysiological hypotheses could explain this phenomenon. The first one is what is called the remote ischemic preconditioning, or RIPC, which is a mechanism secondary to subclinical ischemia and local microcirculatory ischemic conditions caused by the creation of AV access through the release of nephroprotective immunomodulatory humoral factors into the systemic circulation, but also the hemodynamic consequences secondary to the access creation, which manifests by better renal perfusion due to an increased cardiac output and a decreased peripheral vascular resistance. So the objectives of our study were first to compare in a multi-center prospective cohort of chronic kidney disease patients the slopes of kidney function decline before and after first AV access creation. Then to identify groups of kidney function and the patient's characteristic associated with these trajectory groups. So we relied on the CKDopps cohort database, which is the French component of the CKDopps, composed of a total of 3,033 patients with moderate to severe chronic kidney disease. Eligible patients for our analysis were those having their first AV access creation during the 5-year active follow-up and before any start of kidney replacement therapy. So the final number of included patients was 415. The used statistical methods were first piecewise linear mixed effect models to study the difference in slopes of kidney function decline before and after AV access. Since it consists of modeling longitudinal data, in this particular case, repeated quantitative measurement of kidney function as expressed by eGFR as a function of time distributed around the critical period, which is the intervention. And two sensitivity analyses were carried out. The first one aiming to consider a latency period for the effect of 4 weeks after the access creation date, and the second one aiming to exclude any eGFR measurement available before the first year preceding the AV access creation. In order to identify groups of kidney function trajectories before and after AV access creation, latent class mix models were used, and these models permit to relax the assumption of homogeneous trajectories as opposed in a classical mixed model by assuming the presence of several classes, each one of these having its specific trajectory. The key selection criteria that were used to choose the best model were clinical relevance, Bayesian information criterion, and discrimination power. So concerning the results, median age at the access creation was around 67 years. The sex ratio was 2 men for 1 woman, and 18% of patients were at stage 3 at the inclusion. The median time from access creation to the event of kidney replacement therapy or death was around 0.6 years, and the shown graph represents in fact the model-based individual predicted trajectories, estimating the slowdown of kidney function decline after access creation to be around 1.7 milliliter per minute per year, which was, by the way, significantly different from 0. This result was consistent and reproducible after carrying out 2 sensitivity analyses as previously mentioned in the method section. The latent class modeling suggests the presence of 2 trajectory groups and confirm in a certain way the previous findings of the mixed model. As shown by the graph, we can notice the presence of a minority class of nearly 15% of patients with a rapid decline before and after, versus a majority class with a less rapid decline. However, the 2 classes share the same phenomenon of slowdown of kidney function decline after access creation, estimated for both to be at nearly 1.9 milliliter per minute per year, so not far from the estimated slowdown of 1.7 already mentioned in the first objective. Patients in the rapidly declining minority class appear to be younger, more diabetic, and having a high proportion of diabetic nephropathy and glomerulonephritis as a primary cause of the disease, over 60%. So to conclude, our study shows a significant slowdown of kidney function decline after AV access creations, and the results are in fact robust to the different eGFR trajectory groups suggested by the latest class modeling. Causation remains to be assessed due to the observational nature of the study. And beyond our preliminary results, several perspectives have already been identified and are currently being worked on, within particular conducting sensitivity analysis using the spline function in order to consider and address the fact that the evolution trajectory of kidney function is not strictly linear. And thank you for your attention.
Thanks so much, Abdel. Hi, very interesting presentation, and we will have time at the end for questions and for discussion. Wanted to now transition from vascular access to conservative kidney management. I think this is a very important topic and has received a lot of attention in the nephrology community recently. And we have now, to prepare for that, again, a quick poll here for you to answer. So we wanted to know for how many patients in your practice this option of offering conservative kidney management is considered. Here are the options that you can choose. And just for clarification, with this has been the term that is preferred by the community for use, conservative kidney management, that includes not only keeping clinical management with patients without initiating a kidney replacement therapy, but also offering palliative care. So please take a look at that and vote. And in a few seconds, we'll transition to the results of this poll. And here we are. So this is very interesting to see that that up to 5% of you actually that you consider that this could be an option for up to 5% in about a quarter of the respondents here. Interesting to see that about half are considering that this could be an interesting option for your patients with advanced CKD. And I think to advance on that, it would be really nice to hear from Dr. Jennifer Scherer from the New York University School of Medicine. Her presentation that is based on work that she's been doing as part of a grant that she received from NIDDK. And Jennifer is in a great place to talk to us about this, since she is a specialist both in nephrology and also in palliative care. So let's hear from Jen.
Hi, my name is Jennifer Scherer, and I work at the NYU School of Medicine, and I am both a nephrologist and a palliative care doctor. My project with CKDopps was looking at conservative kidney management in the United States. So the objectives of the talk are to begin by defining conservative management and why it's important to talk about this treatment option, and then to look at our conceptual model and the analytic approach that we took to discuss how we determine our cohorts for analysis, our results, and finally our conclusions. So we'll start with the first objective. And just to take a step back to define conservative kidney management, there are a few definitions out there, but the one that I usually use is to describe the treatment option as a holistic approach to kidney failure that focuses on quality of life goals, symptom control, and emotional support without initiating dialysis, while focusing also on preventing the progression of kidney disease. Excuse me. So it still is medical treatment. Data shows that this may be an appropriate treatment option for older adults with multiple comorbidities, particularly those with ischemic heart disease. Of note, these are not randomized controlled trials, but rather observational studies. What these studies do show is that the treatment choice of conservative management may preserve quality of life for these individuals, whereas initiation of kidney replacement therapy may not necessarily lead to life extension. We do know that those that initiate kidney replacement therapy are most likely to have more time loss, which is defined as time in the hospital away from their families, and are more likely to die in the hospital with medicalized deaths. The delivery of conservative kidney management has no consensus currently, and the role of palliative care, which is a specialty that assists with complex symptom management, emotional support, complex medical decision making, and end-of-life care planning and care delivery. The role of palliative care is unknown in the delivery of conservative kidney management, and currently there's no capture of data about these patients in the United States. So the objectives of our project are to leverage the US data from CKDopps to describe, 1, patients who choose conservative kidney management, 2, provider practice patterns relative to CKM, and 3, CKM resources available to providers. So now we'll discuss our conceptual model and analytic approach. So we decided to approach our analysis really trying to honor and reflect the complexity of the decision of choosing not only kidney replacement therapy, but the decision to forego it and choose conservative kidney management. And we decided that there are several factors that influence this decision, one being clinic factors, the other being patient factors related to age, gender, functional status, comorbidities. Then the third factor is kidney failure education, how conservative kidney management is brought up in discussions of treatment options, delegations of responsibilities for education and for delivering CKM, as well as access to palliative care, provider factors, and then there are other factors that are not measured in our data, including family history, spirituality, prior experience of palliative care, individual values and goals of care, although we do have patients' DNR status and provider training and education in conservative kidney management and palliative care, with the recognition that no matter how many quantitative analyses you do, you're not going to fully capture the nuances of shared decision-making for patients. So now we'll look at how we determine our cohort for analysis. And the first cohort that we analyzed was really the patient anticipated choice. And these were patients from the ISMQ surveys where they had answered yes to the question, has a decision been made for conservative management without dialysis or transplant at the time when dialysis or transplant would otherwise be initiated for kidney failure? So all the patients who were given this question had already said they had not decided on a treatment modality for kidney replacement therapy. So just to summarize, we analyzed only the first survey of the patient, and we analyzed all patients who had a GFR less than 30. And in the end, we ended up with 1,018 unique patients, and 7% or 68 patients were categorized as anticipating a choice of CKM, and 950 or 93% were categorized as not choosing CKM. We also included patient responses, and this is from the patient questionnaire. And in this survey, we actually divided the data by looking at patients who had discussed CKM, which was the question from the survey was, has your provider discussed not starting any therapy at all, versus those who had not. And we also only took the surveys that had a GFR less than 30, and we also were looking at the first survey where this question had been answered. So we ended up with 407 surveys from unique patients, with 74, 18% saying they had discussed conservative kidney management with their provider, and 333 saying they had not. For the cohort that was going to represent the clinic data, we used the answer to the question, for patients seen by a nephrologist for at least 3 months before starting dialysis, are palliative care specialists typically involved in educating about and planning for ESRD, including dialysis, transplant, or conservative care? The answer choices in the survey there were no, sometimes, and yes, and we categorized sometimes and yes as yes, and no obviously as no. Of note, the individuals who were offered this question were either clinic director or study director, and we ended up with 18 unique surveys representing unique clinics. So our results. So the key results, so our table 1 from the paper we submitted show the demographics from the chart abstracted data of those patients who had a GFR less than 30. Of note, this was recorded by the research coordinator. And so the key points was that 7% of these patients had anticipated choice of conservative kidney management, and their mean GFR was 19. They tended to be older. 79 versus 68, more likely to be non-Hispanic. A significant minority, 40%, lived in the central region of the US. More were married, 55% versus 52%. Fewer lived alone, 33% versus 36%. They were more likely to be retired or disabled. And importantly, they were less likely to ambulate or transfer without assistance, meaning they weren't able to do these without someone helping them. And they were more likely to have all comorbidities with the exception of hypertension or diabetes. Now, when we looked at the patient recorded data, 18% had said they discussed CKM with their doctor. The GFR was 21. They tended to be older, 70 versus 68. They were more likely to not know which treatment they would choose at the time of kidney failure, 61% versus 58%. They were more likely to be white. Sorry, this is a typo. This shouldn't be here. This is from the other side, so ignore that. Fewer were married. More lived alone. More were likely to transfer independently compared to what we saw in the ISMQ. And they were less likely to have not discussed treatment choice with their provider, 9% versus 49%, but overall less likely to have discussed all other treatment options. So table 4 was the one that showed the clinic characteristics. And what we found was that 6 clinics representing 33% were able to involve palliative care and ESKD education. All of our respondents were nephrologists. What's interesting is that regardless of access to palliative care, very few clinics directors or study directors said that many patients were going to choose CKM. Most of them said about 0 to 5% of their clinic population had chosen CKM. With the overall trends of the providers were that most, nearly 100% or a very significant majority, said that they were comfortable discussing conservative kidney management. They typically discuss it as a treatment option. They routinely offer it, and they offer it very often to older adults. But then when we started asking about, resources or, pathways for this delivery, very few had said there was a written protocol or guideline for CKM. Very few said that they had a dedicated CKM clinician or CKM clinic. Almost all of them that responded to these questions did say that the nephrologist usually always continues to provide care. And almost all of them said that palliative care doesn't get involved when the patient chooses this pathway. Another interesting finding was that there was inconsistent nomenclature in the terms chosen for conservative kidney management, ranging from conservative, palliative, supportive, non-dialysis, or other. And so this could be confusing, obviously, if patients are going to different ERs and using different terms to describe their treatment choice. So then another question that was interesting from the provider perspective is they looked at the influence of patient characteristics and providers contemplating the suitability of CKM for a patient. And what we saw was that it was mostly things like patient preference, frailty, functional status, quality of life, some influence of uremic symptoms, 47%, and less likely kidney function. So our conclusions are very low percentage of patients had anticipated choice of CKM. I don't think it's surprising that they were more likely to be older, functionally dependent, and possibly with support at home, which has been shown in other studies. Most providers felt comfortable discussing CKM with their patients, and they were influenced by things that we often don't train fellows to recognize or we're not well trained in, such as frailty, assessing functional status, rather than disease-centered characteristics when deciding if a patient is suitable for CKM. 18% of patients reported having a conversation about this treatment option. However, most providers said they were comfortable discussing it and that they were discussing it with their patients. And I think a very important take-home message is that few clinics had dedicated resources for this treatment pathway and that there was inconsistent nomenclature. Our limitations as a small number of responses. The responses were not linked, the patient responses to provider responses. It was the patient anticipated choice was filled out by a study coordinator and may not represent what they ended up choosing. And we didn't track the changes over time. So, but I think it's very hypothesis generating, and I think it gives us a sense of the state of practice in a likely representative sample of clinics, and this has not been described before. Hopefully we could look at the same questions using a larger sample size, more consistent nomenclature in the surveys as the questions are worded, and maybe the possibility of formulating a registry for patients who choose this pathway. So just to mention to the people who have all helped me, the team at NYU, the CKDopps team, and obviously my funders, the NIDDK, my K23 and the Young Investigator Award from NKF. So thank you.
That was really great, Jennifer. Thank you very much for sharing this information with us. I'm really looking forward to the discussion, especially after hearing the results of our poll today. So this is going to be the last presentation of our CKDopps session, and just to kick off that presentation, that will be based on kidney failure risk equations. I wanted to again, and for the last time, bring a poll to you. So the last poll that we wanted to ask you to respond is, do you use equations to estimate the risk of kidney failure in your local practice? And here are the options you can choose from. We wanted to see if you use that basically to tell patients when they might need to start dialysis in conversations you have with patients when they get closer to that decision. Or maybe use that for planning dialysis preparation, like listing or planning for vascular access creation. Maybe you'd use it for both, or maybe you don't consider that useful. So it'll be really interesting to hear what you think. And here are the results. So it seems like about 10% of you actually use it for individual reasons, talking to patients or planning. About 45 use for both. And about a third of you actually don't use it very broadly in your practice. So great to see these responses, and a great segue to our last speaker, Dr. Chi Chu from the University of California in San Francisco, waking up very early today to give this talk. And we'll hear from Chi about his work with CKDopps. So take it away, Chu.
Hello, everyone, and welcome. My name is Chi Chu. I'm an assistant professor in the Division of Nephrology at UCSF. And today I'll be talking about estimating time to kidney failure, comparison of kidney failure risk equation, and eGFR thresholds. These are my disclosures. And so in taking care of patients with advanced CKD, we historically trend creatinine and eGFR. This is how we stage CKD, and many clinical decisions are based on cutoffs of eGFR, such as when to refer a patient to nephrology, transplant referral, transplant waitlisting, and when we think somebody may be nearing kidney failure and the need for dialysis. In the past about 10 years, the kidney failure risk equation, or KFRE, was developed, which is a widely validated model for predicting the risk of kidney failure at 2 or 5 years among people with CKD. And it takes as its inputs age, sex, eGFR, and urine albumin-creatinine ratio. As you can see on the right, we put in these 4 variables. This is an online calculator, and it outputs the 2-year and 5-year risk of developing kidney failure, which was defined as either requiring dialysis or receiving a kidney transplant. And this kind of risk assessment can be used to guide various clinical decisions over the course of CKD, so things like when to refer a patient to nephrology, or when to plan a transplant or vascular access. And so the rationale for the present study is that for expressing prognosis, patients and clinicians are often interested in the time to kidney failure. So a patient may ask how long they have, how many months or how many years the doctor thinks they have until they would need dialysis. And also, clinical decision-making for patients approaching kidney failure could benefit if the KFRE risk were translated into time to kidney failure. So for example, if a patient opts to do hemodialysis, then knowing the expected time that they have until they would need dialysis could help the nephrologist plan when to start the process of vascular access planning, as they need to consider how long it takes for vascular referral, vein mapping, surgery, maturation, etc., in their own health system. And so the goal of our study was to examine correspondences between KFRE predicted risk and time to end-stage kidney disease. And so for our study, we used data from the CKDopps US cohort spanning 2013 to 2021. We included patients with available data to calculate the KFRE. So this is serum creatinine for EGFR using the CKDopps 2021 equation, and urine albumin creatinine ratio. And where that wasn't available, we substituted urine protein creatinine ratio or urinalysis protein, which we converted to UACR using validated equations. And the UACR had to be within 365 days of the EGFR. And to construct our analytic cohort, we allowed each patient to contribute multiple risk periods corresponding to repeated EGFR and UACR values obtained over the follow-up period, using robust standard errors to account for clustering by participant. For our analysis, we fit accelerated failure time, or WIBLE models, to examine the association between the 2-year KFRE predicted risk and time to kidney failure. And using a parametric survival model such as this allowed us to characterize associations in terms of time and allowed for direct estimation of the distribution of time to kidney failure. And from this, we were able to estimate median and interquartile range estimates for the time to kidney failure corresponding to set KFRE thresholds of 10%, 20%, and 40%. And we also compared the time to kidney failure by patient characteristics, so age, sex, race, diabetes, and albuminuria status. And then for comparison, we repeated these analyses, but using EGFR instead of the KFRE risk as the primary predictor, using EGFR thresholds of 15, 20, and 30. And so this was our final study population, included 1634 participants total, with a mean age of 68 years, nearly half female. Mean EGFR was 29 with a standard deviation of 12. Median UACR was 104 milligrams per gram. Patients contributed a total of 9,886 risk periods over a median 1.6 years of follow-up, over which time there were 266 ESRD events and 178 deaths. And so this is the main result. This is a figure showing the median and interquartile range of estimated time to ESKD for each population. On the top, we have the EGFR thresholds. The median times to ESKD, as you can see here, were highly variable, especially from an EGFR of 30 or an EGFR of 20. Conversely, when starting from an EGFR of 15, or when starting from any of the KFRE thresholds, there's much less variability across the subgroups. Limitations of our study included the missingness of UACR, although the calibration of the KFRE was still good, even with the substituted UPCR or urinalysis values. The relatively short follow-up time in the US cohort that we had. And I think the main limitation is that competing risks are not considered in the time to kidney failure framework. Conceptually, if the prognosis is a time, like a number of months, which is what we're trying to estimate, then it doesn't really allow for any accounting of a competing event like death occurring before kidney failure. And so as a result, in terms of interpretation of these results or interpretation of any kind of predicted risk, clinicians still need to consider the risk of death alongside these predictions and ultimately consider what's best for the individual patient. And so in conclusion, we provided estimates of time to kidney failure corresponding to a range of KFRE and EGFR values. Among patients with advanced CKD who are actively followed in nephrology practices, the kidney failure risk equation provided more consistent and equitable estimates of time to ESKD across patient characteristics compared with EGFR. And these results also support use of the KFRE as an adjunct for informing time-dependent decisions in preparation for kidney failure. Thank you.
Thanks so much, Chi. It was a very, very comprehensive presentation today. And now let's get our panel together here for the discussion. We do have about 10 minutes for questions from the audience and for discussions. So very, very happy to have all panelists gathering here. And we do have some questions from the audience already. And I have some questions that I'm curious about too. So why don't we start with you, Jennifer? Just bringing back, what we heard from our audience today about, their perspective on, patients who could be considered for conservative kidney management. 10% is the favorite response, meaning half of the audience actually felt that about 10% of patients should be considered, their patients should be considered for conservative kidney management. How do you see this kind of response compared to what you saw in your study and your own clinical experience?
The 10% was actually a little bit higher actually than what we saw. We saw that most people said 0 to 5%. So that could reflect just the timing because the study data is a few years older than how we're practicing now. And a CKM is definitely being spoken about a lot more. So that could just be a trend over time. I still think it feels a little low. I feel like most nephrologists do see a lot of patients who are older adults with high comorbidity burden, where particularly ischemic heart disease, it's like almost, a lot of our practices. I think it still could reflect, kind of a lack of consensus of delivery guidelines for how to actually give conservative kidney management, and also possibly the lack of resources that people have to deliver it. It also could reflect the culture in the US. I do find that it is a hard decision to get people to agree to here. And a lot of times people would feel more comfortable with the possible trial of dialysis or not committing to conservative kidney management and committing to deciding later. But I think it would be interesting to see how the survey results change over time as the literature and the field of nephrology is changing.
Yeah, no, absolutely. There's a lot of people talking about this, right? And initiatives from, organizations, including, I know you've been involved with the International Society of Nephrology group that's trying to put together not only some, guidance on how to do it, but also some educational material. Do you think that this is really gonna be out for most people in the coming months or years?
I do think we're going to see changes. I think as the pathway becomes more supported and as like infrastructure changes to care for these older adults who may not want dialysis, or where dialysis may not be the best choice. We also don't know a lot about how home therapies will fit into all of this. So I think there's still a lot of unanswered questions, but I've seen just even in my own institution, just having me on faculty, I went from having like 0 referrals to, people writing very comfortably in their notes, patients should see palliative, not start dialysis, and actually seeing it happen rather than the patient getting admitted to the ER and start on dialysis in the end.
Mm-hmm. Yeah. Thanks. Well, Abdel, I wanted to ask you here a question that came from the audience, and that's related to the location of the AV access. Have you looked at the, like upper arm or lower arm fistulas, if there is a difference in what you see in terms of the responses? Sorry, I think we can't hear you. I don't know if you're having some problems with your audio. Well, we'll move to another question to see if we can you can solve your audio technical problem here.
Do you hear me?
Okay, now we can hear.
Well, yes. So we have not looked for this information yet for the location of AV access, the relation between the location of AV access and the EGFR decline.
Yeah, might be something very interesting to look at due to the characteristics in terms of this, ischemic reconditioning
Exactly.
theory or hypothesis, right?
Yeah, right, exactly.
Yeah, and one more thing, I don't know if you had the chance of doing that. One thing that, I mean, you highlighted that there are some confoundings there, but how about the fact that perhaps once fistula is in place, that maybe the visits to nephrology might be much more frequent, and this might be one of the reasons why patients might be experiencing delay due to optimization of treatment or increasing visits.
Yes, exactly. Actually, there are multiple hypotheses for a potential false positive result, and what you're talking about is actually a statistical phenomenon called regression toward the mean, where the decision of AV access is often occurs after periods of faster progression, statistically followed by a period of slower decline. There are also other hypotheses, like, for example, an increased patient awareness to the CKD condition, with a consequent better compliance to medical treatment, to a protein-restricted diet, and to medical follow-up. And also, probably AV access is created at a certain time point where uremic symptoms are more disabling. And I think that any estimated GFR based on serum creatinine could be falsely interpreted into a slower eGFR decline because of maybe a lower dietary intake and reduced muscular mass. So,
right. Yeah. Thanks very much, and congratulations for the work. I think this is going to be really well received when you present it in Orlando in a couple of weeks from now.
Hey, Roberto. Yeah, this is Ron. Can you guys hear me?
Sure. Yeah, go ahead.
Abdel, yeah, I really enjoyed your presentation as well. I was just curious, in the future, maybe as a post hoc analysis, we all know that not all AVFs are created equally. And typically in Europe and the US, only about 2/3 of them, at most end up to mature so that they're successfully used. And I guess it'll be interesting to see later on, as patients do start dialysis, was that AVF actually, did it successfully mature to be used? And it could be, that would be another checkpoint as well, to see that actually in the patients where the AVF successfully matured, then the impact on the eGFR slope maybe was substantially greater than in those AVFs that ultimately were found that they didn't successfully mature. It's just a thought for the future.
Thank you.
Yeah, thanks, Ron. Maybe we'll go to Chi now for a couple of questions. And it's interesting to see that about 1/3 of our audience is a bit skeptical about using formulas in their practice. What do you think is the main limitation that leads to that perception, G?
I think there are probably a number of barriers to uptake of the KFRE, but a lot of this, I think, is also shared by a lot of prediction models in medicine. I think we're seeing a lot of papers that come out, developing and validating new prediction models for various outcomes, including other models for kidney failure. But I think the bottleneck is always in implementation, and in that area, the KFRE has gotten probably more uptake than any other model in for kidney failure, but even then it's still pretty poor. It's available online. It's available in apps like MD Calc and etc. So it's gotten that to that level of dissemination. But I think in terms of, like, I didn't learn about it until nephrology fellowship.
Yeah.
So whereas other models might, like things for like, TIMI score, Wells criteria, these are things that people learn in medicine. But so I think there's a lot of work in terms of dissemination, but also the bar for dissemination that people want to see. Often people are, will want to see evidence that using it improves outcomes in, rigorously designed studies. That's a pretty high bar. And so I think that's one that is still a work in progress. Although a lot has already been done, but I think it's there's, yeah.
I was wondering, I mean, one thing that at least outside of nephrology, but even within nephrology, the availability of UACR, and sometimes it could be surprising how not every patient has it, and it's required for the formula. Do you, and you did something interesting because you used that conversion approach that you got, dipstick results and proteinuria and brought it to the, to the single measurement that could be used in the formula. Do you think that was did you feel that this was a consistent thing, applying this approach, and this could be also advised that people can do that if they wanted to?
So when you do the conversions, I think it still works pretty well. And for UPCR in particular, like that was shown in the paper that they developed the conversion. They actually validated it using the KFRE as well to show that that the predictive performance was still preserved. But I think the barrier, like you said, in real life is that there's also a lot of people who don't even have proteinuria, like UPCR or urinalysis, although less ideal, but there's still a lot of people who don't have any urine protein assessment.
Yeah.
So.
Well, Cheat, thanks so much, Jennifer Abdelhai. It was, I think it was a great session, great discussions. Thanks for being with us today. And I think with that, I'll close the CKDopps session and pass the mic back to Bruce for some final remarks. Bruce.
Roberto, thank you very much, and thanks everyone once again. Actually, just to give a quick review of the 3 hours that from my point of view passed very, very quickly, and illustrative of all the great work that is being done. On the DOPPS session, just wanted to highlight the hemodialysis. Just wanted to highlight the value of the electronic PRO, patient-reported outcome tool that we're now utilizing to capture, for example, really sort of high fidelity information regarding pruritus or dialysis itch, which is so important to patients. We're using it as well to look at the experience of incident dialysis patients. We have some folks in Europe, colleagues who are seeking funding to look at cognition and change associated with that transition to dialysis, early dialysis period. So a ton going on in that space. On the peritoneal dialysis side, or PDOPPS, in terms of innovation, once again, just putting the patients first just comes forward so clearly, Jeff, from what you've done and led, and from what others have presented, whether it be a focus on drain pain, on PETs, use of CAPD versus APD, and the example of hypokalemia using DOPPS finding, and then our wonderful colleagues in Thailand running a clinical trial corroborating findings of the dangers of hypokalemia, leading to already to changing clinical practice that Simon Davies has spoke to, was just wonderful. On the CKDopps side as well, so much for us that we have done, and so much to do moving forward, as Dr. Scherer mentioned, for example, in the conservative kidney management space, a lot more for us to do with this platform that we've set up. I really love how you say, rather with the KFRE kidney risk prediction equations, the question is, doc, how much time do I have before I start? Not what's my chance of being on dialysis at 2 years or 5 years. I really love that patient-centered focus. So much more to do, and thanks to everybody. Just to highlight in the closing moment, again, we have a ton going on at ASN, as shown here. We also have handouts that you see available that list all of the activities at ASN. Next slide. And we also have our social, just to remind folks of our mixer on the evening before the ASN launches. Really looking forward to seeing folks. Next slide. Heartfelt thanks to everybody. We're really looking forward to future work together with you to meaningfully improve the lives of kidney patients. And our final slide is a picture, right, a photograph. Again, it really does take a village, all of us working together. This is a photograph from in the sunshine at in Vienna at EDTA about 5 years ago, but just illustrative of the work of so many folks worldwide who have done so much together, and we have so much more to look forward to. Many thanks to all for attending, and we look forward to seeing many of you at the ASN. Thanks so much.